This slide reflects the Commission's goals as outlined in its strategic plan, which continue our commitment to advancing the vision of well-being for all Californians. At today's meeting, we will be discussing full-service partnership funding, the Mental Health Student Services Act report, and will receive an update on Proposition 1 implementation planning. These topics align with our strategic plan goals to champion vision into action and relentlessly drive expectations. You will also notice that many of the agenda items have icons next to the titles. These icons represent the strategic plan goals associated with each agenda item. Thank you. Thank you, Cody. So we are now going to take roll to establish a quorum. We would like to note for the record that we currently have a quorum of 8 commissioners in person. We have one vac.
Yeah, we have 7.
Honor's on our way.
Okay, we're going to wait on the roll. We are waiting on one more commissioner to come into the room. So we are now going to then go ahead and move on to agenda item 2, announcements and updates. However, before we get started, I would like to take a moment to introduce and welcome Dr. Gloria Cediza, San Diego County's Superintendent of Schools. So at this time, Dr. Cediza, please.
Should I?
Please, to the podium, that'd be great.
Feels a little off.
We can turn around and roll.
I understand this is a bigger stage. Good morning, everyone, and welcome to San Diego. I am honored to welcome you all here to SDCOE for the Mental Health Services Oversight and Accountability Commission. As Mara said, I'm Dr. Gloria Cediza. I am the San Diego County Superintendent of Schools. It is without question that addressing the mental health and wellness of our students is one of the most important issues that we face right now. We've all been through a lot since the pandemic, and it has changed the everyday life for all of us, and specifically for our children. It has, what we know is that it has changed everyday life for all of us to the extent that we haven't seen since World War II. Just let that sink in for a moment. That's significant. It's no surprise that millions of adults and youth alike are feeling overwhelmed. The work that you're doing to support our youth and our educators is so important, and I applaud your dedication, your passion, and your commitment to our students and families. The U.S. Surgeon General has described what our children are currently facing as a mental health pandemic for youth. To address the youth mental health pandemic in a relevant and compassionate way, we must work together across all of our systems and disciplines. And for that, I'm very pleased that today, Dr. Luke Bergman is going to be here this morning to welcome you as well. Here in San Diego County, our school and health systems work together in unison to address the needs of our youth. Mental health goes beyond the absence of illness. Mental health involves the capacity to function mentally in all aspects of one's life, to be productive, build fulfilling relationships, and adapt to life circumstances. Our school communities are intent on working to ensure that our youth are safe and cared for and have the tools they need to succeed. At the San Diego County Office of Education, we're focusing on our North Star goal, which is to reduce poverty in San Diego County through public education. Sorry about that, I lost my train of thought there. Part of that effort is creating a culture and an environment in which our students and families and our staff feel a sense of belonging and safety. So SDCOE is leading a comprehensive mental health and wellness effort, including mental health literacy, stigma reduction, suicide prevention, and coordinated referral pathways for students in need of services. I'm very proud of that work that our team does for our school communities, and I'm committed to ensuring that every student has the mental health supports they need and deserve. I appreciate the efforts of the OAC, and I'm very, very proud of our commission's chair, Ms. Mara Madrigal Weiss. She's a superstar here at SDCOE and at the state level and beyond and beyond. So we're very proud of Mara's work.
That's right,
Yeah,
Mara.
she's a pioneer. So here at SDCOE, we're leading by example through Mara's leadership. We've contributed to and have integrated best practices and policy recommendations highlighted in the OAC reports, including schools as centers of wellness and striving for zero, which is the statewide suicide prevention plan, and the well-being and thriving and the Well and Thriving PEI report. So I'm encouraged by your recent report on workplace mental health and have approved the integration of our voluntary workplace standards into our very own County Office of Education. So thank you, Mara, for leading that work with us. I am just so pleased and so honored to host all of you here today to conduct this very, very important business that will help to improve behavioral health for all of Californians. So thank you for your dedication, for your work, your commitment to this. Welcome. Thank you for being here. Keep doing the good work. So welcome.
Thank you.
Thank you so much, Dr. Sidisa, for that warm welcome. And we will continue to move forward and prioritize student mental health and the well-being of all Californians. So with that, we are going to move on, and we are going to move on to this month's announcements by sharing that this month Commissioner Itai Danovich completed his term on the commission and will no longer be serving as a commissioner. The governor's office is vetting potential candidates to fill his position. We will be honoring Dr. Danovich's 8 years on the commission with a resolution at the September commission meeting in Los Angeles. Yesterday, Commissioner Alvarez and a few commission staff were able to visit For the Village. For the Village provides free doula services to all families in the San Diego area, with an emphasis on marginalized groups, people of color, LGBTQIA, and low-income families. Commissioner Alvarez will share some thoughts on that meeting and what it was that they experienced there. And so we are just, we will move on until Commissioner Alvarez arrives. Next, I would like to let you know that a legislative update is in your meeting packet, and it includes information on bills supported by the commission that are on their way to the governor's desk. More information on the status of all bills will be provided to us. If you have specific questions, please reach out to Legislative Director Kendra Zoller, and she will be able to provide that information. I'm also excited to announce some events that we are hosting in the coming months. As we wrap up the Impacts of Firearm Violence project, we are holding 2 final community engagement events in September. The first event will be in Lassen County. The second event will be in Los Angeles. In partnership with the Council on Criminal Justice and Behavioral Health, the Commission is sponsoring Words to Deeds 2024, a convening to bring together thought leaders from a variety of sectors to establish metrics to measure success in preventing people with behavioral health issues from becoming involved with the criminal justice system. These metrics will be useful to policymakers, service providers, and members of the public in the work toward reducing criminal justice involvement and promoting the goal of prevention and early intervention. All commissioners are invited to join us at both events and can reach out to staff for more information on registration. I would also like to share that the commission has been invited to attend and participate in some important events highlighting our work in the behavioral health field. The first of which is the Diana Awards. Established in memory of Diana, Princess of Wales, the Diana Award is the most prestigious accolade a young person aged 9 to 25 years can receive for their social action or humanitarian work. Toby was invited to attend this event on behalf of the commission. Toby Ewing and Commissioner Carnevale will also be representing the commission at the Berkeley Innovation Forum, where they will discuss how emerging healthcare technologies and business models may transform our future, specifically around open innovation in global healthcare. And finally, Toby Ewing and Commissioner Carnevale will be moderating a fireside chat hosted by the UC and CSU Collaborative for Neuroscience, Diversity, and Learning in September at UCLA. The purpose of the fireside chat is to connect emerging research to evidence-based policy and practice. We are very excited to have Toby and Commissioner Carnevale representing us at these events. Since our last meeting, both the CLCC and CFLC committees have met. I would like to invite Commissioner Chambers at this time to share more about what was shared within that committee. And
Pulling up my notes. Sorry. All right. Do you want to hold off or do you want to?
no, please go ahead.
Okay, so I'm giving an update on the Client and Family Leadership Committee. So it's good morning, everyone. It's kind of awkward with not having a mic, but it's up here. Yes, yeah, yeah.
Listening to everything.
We got you.
I got you. Thank you. As the chair of the Client and Family Leadership Committee, I'm here to give an update on our last CFLC meeting held on July 17th, 2024. We discussed the role and responsibility of the CFLC in regards to the MHS-OAC strategic plan implementation. We identified 3 committee goals that aligned with the plan's objectives. The goals collectively identified are supporting the organizational capacity building, assisting in developing adequate and reliable funding models, and inspire innovation and learning by curating an analytical-based narrative to improve behavioral health outcomes. So we're really excited for those 3 goals. General comments also detail how peer-run housing, which I'm excited about, the peer respites coming up, throughout the state could be a welcoming innovation and be and examine ways on how we may be able to practically measure our success as we go about each of these goals and objectives. Our hope as a committee is to stay adaptable to any changes that may occur due to Prop 1 and embrace transformational change by being proactive in our efforts to improve mental and behavioral health programs and initiatives. I'd like to take this time to thank the members of the committee and the public that have just showed up and showed out and really come and really just made our conversations really robust and came with solutions. Your input and feedback has been like instrumental and important to making things happen. And I'm looking forward to seeing the difference that we can make in the committees and really getting informing the full commission on our priorities that align with the strategic goals. So I just want to thank you all and the committees and for the public, if they want to join the committee, please come, because I think that's where a lot of the work is being done in the committees and outside with the other commissioners as well. Thank you.
Thank you, Commissioner Chambers. And I love that. Showed up and showed out.
Oh, they showing up.
I love that. Thank you, Commissioner Chambers. Commissioner, Vice Chair Artis, you could please provide an update on the committee.
Sure. So the Cultural and Linguistic Competency Committee met on, actually just this week, on Monday afternoon, and had a robust discussion about how the committee and its structure can support implementation of the commission strategic plan. And in particular, how can we ensure that the expertise and perspective that our committee members are bringing as representatives from marginalized communities or organizations that are serving particularly marginalized communities can better guide the work of the commission. So our conversation really revolved around what are those concrete actions that can be included as part of the committee work, everything from reviewing RFPs that are supposed to meet specific goals of the commission, to stakeholder engagement and the work that our advocacy partners are doing and how that contributes to the work of the CLCC, or how the CLCC can be a good partner. Be a good partner in that work. So it was a good discussion. We also discussed committee makeup and the importance of filling in the gaps of our committee members, just recognizing that we're in August, but 2025 is just around the corner. And to Commissioner Chambers' comments, next year will be a very exciting year for the commission with a lot of questions that we'll be facing. And we'll need to rely on the expertise and guidance of our committees in order to be that much stronger in our response to implementation of Prop 1, but most important to our implementation of our strategic plan and the goals that we have set forward. So we do plan on bringing in new members of the committee in 2025, and over these next few months, we'll rely on our existing committee members for their guidance and expertise. The last thing I will say, and I just want to give credit and acknowledge the great comments from both our committee members as well as members of the public, is that there continues to be this deep appreciation for the commission's commitment to stakeholder engagement and to listening to community. And that is an asset that this commission brings not only to our work, but to the collective work of the administration and its commitment to mental health. And so figuring out how to really leverage the strength of committees is a question at the top of my mind, and one that I look forward to working with the chair and our commission to figure out for the future. It's one of the goals or the priorities for implementation of Prop 1, and I think it's a long time coming. I'm looking forward to that conversation.
Absolutely. Thank you, Vice Chair. Vice Chair, I would also add if you could provide us an update on your visit to For the Village.
Yes, absolutely. With huge thanks to Ryan and Tom and Jigna, we had the opportunity to visit Urban Restoration Counseling Center yesterday in San Diego. They are a BIPOC-led mental health counseling center in the community. And as they call it, it's therapy for all. That's one of their programs, really opening the doors to everyone regardless of their ability to pay, and figuring out a way in which you can help community members so that they not only help themselves, but they help their families and they help their communities thrive. It was an incredible model. And at the same time, they spoke to the importance of community partnerships between community mental health centers and other partners who experience clients that have mental health questions, that have mental health challenges, and that need somewhere to go through a trusted source. So the other partner that we were able to connect with was For the Village. And For the Village is a community-based doula network in San Diego. Again, also majority doulas of color, Black doulas and Latinx doulas, Indigenous doulas that help birthing people have healthy babies. For those of us that are aware, California has one of the worst disparities when it comes to birth inequities, particularly for Black birthing people. Black women are dying at a rate 6 times of white women in California. And that also leads to trauma, it leads to mental health crises, it leads to not only for the birthing person, but for children as well. And so they spoke a lot about the mental health impacts of watching these traumatic births for the doulas themselves, as well as for the women and birthing people going through the experience. And how that warm handoff to this mental health center is only possible because of that relationship that is supported by county funds, by private funds. So it was just an incredible example of lifting up community leadership and where there is wisdom and leadership in community members. And I'm just incredibly grateful to the team for making that possible, and to this commission for your commitment to investing in this population through our Mental Health Wellness Act dollars that we've talked about over months now, actually probably a year. And I'm looking forward to bringing back to the commission additional information on these investments in the future.
Please, Commissioner.
I'm just so excited about your visit. I just met in Oakland with the California Health Care Foundation with the top doulas in the state, the promotores and the community health workers. And we talked a lot about managed care plans and about like the need for us as practitioners of lived experience. We called ourselves, or I called us, to come together to advocate for more equity and I don't know, getting benefits out to Medi-Cal recipients and just equity and pay for us across the board. And then just as someone that almost died in birth as well, and had all the resources, it doesn't matter particularly about social economic status, particularly with Black women, we're just dying and we don't even know why. So the importance of linking like the postpartum as well and the mental health is so real. And I just want to make sure the health plans hear about the need, the commercial and the county managed care plans about the need for the continuum of care for birthing individuals, and women, with mental health, as we give birth and try to come back and live and thrive in community. So I just wanna thank you so much. And I've just learned so much in the last couple of weeks and months, and just like how our system now and fitting this into the medical model, and how doulas have had to advocate just to get into these rooms. And they're still having access getting into just hospitals to try to serve individuals. So just keep up the work, and I look forward to hearing more about that.
Well, and I think it's really up to us to keep these conversations going and asking for ongoing site visits to this, because we're gonna be forcing the conversation
Yeah,
with Department of Healthcare Services, Public Health Department. So I think we set up more of these site visits to keep that conversation going and lift it up.
they need it.
So it's our work. So let's make sure that we do that. So thank you.
Love that.
Thank you both. Appreciate that.
So go back to.
Yes, so at this time, we are going to go back and establish quorum. So I would ask Sandra, you can do that, please.
First, commissioners, please unmute your lines now for roll call. If you're participating remotely, I will ask you if there is anyone over the age of 18 in the room with you per Bagley key. Additionally, you must remain on camera if participating remotely. If you need to step away or go off camera, please let us know. I will now begin. Bontrager.
Here.
Brown. Bunch. Okay, Brown.
Yeah, I'm here. Can you hear me?
I can hear you. Bunch. Carnivale.
Here.
Carrillo. Chambers.
Present.
Cortese. Gordon.
Here.
Okay. Mitchell. Here. Robinson. Roulette. Vice Chair Alvarez.
Here.
Chair Madrigal Weiss.
Here.
Chair, we have four.
Thank you, Sandra. Okay, so we are moving on. The commission has increased our presence on multiple social media platforms. We share events, resources, information on our latest policy work, and more through our social media, and I encourage you all to follow our work. I want to welcome everyone again into today's meeting. The plan is to end around 3 o'clock. Commissioners who are online, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so the commission staff can make you a co-host again. It is now time for agenda item 3, general public comment. This time is reserved for comments on items that are not on the agenda. I want to note that for individuals providing public comment on Zoom, you will see a small timer in the upper right-hand corner of your screen. This timer will let you know how much time you have left for the public comment. I also would like to note that we have an additional way that you can submit public comment to the commission. Members of the public can email us at publiccomment@mhsoac.ca.gov. Comments submitted 2070, sorry. Rewind backwards. Comments submitted 72 hours prior to the commission meeting will be shared with commissioners at the upcoming meeting. Comments submitted outside of that window will be shared at a future meeting. Public comments submitted to this email address will not receive a written response. If anyone is interested in making public comment regarding the announcements for other items, please make those during the general public comment time. If you have any technical questions, please contact commission staff at 916-500-0577. At this time, I will ask Amariani to go over the public comment procedures.
All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that item starts. You can request a public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. Do our best to take comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue, so please make requests to comment now. The moderator will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete within 3 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair and at least twice the amount of time will be given during the public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen.
Thank you, Mariani. Will you please open the line for general public comment? And do we have,
We don't have any in-person comments. We have 3 virtuals. Our first comment is from Dr. Lynn Rivas. Your line is open.
She's muted.
just one moment, ma'am, you're muted. We're gonna get that fixed. So we'll have you start over in just a moment.
You should see a pop-up box that's asking to unmute. You should accept that.
Did that work?
Yes, that worked. We can hear you fine.
Great.
Your 3 minutes start now. Thank you.
Hi, I'm Dr. Lynn Rivas, and I'm the Executive Director for CAMPRO. And I'm here to appeal to you, not simply in your role as commissioners, rather also as individuals who have an impact beyond this committee on behavioral health care policy in the state of California. I am a person who has lived experience with mental health challenges, and I need and count on peer support. The effectiveness of peer services has been proven by countless studies, and we know that peer-run services are best at maintaining the fidelity to the recovery model. The model is also known to be extraordinarily efficient and will result in your greatest mental health services value. Small peer-run organizations are particularly in peril from the upcoming Proposition 1 cuts. Yet, they're the best equipped to deliver locally informed, culturally competent services that result in more equity for underserved communities. We therefore believe that it is in the interest of mental health consumers in California that rather than cutting peer services, that 10% of all non-Medi-Cal BHSA dollars be devoted to peer-run services. Devoting 10% to peer-run services will allow services to expand and will make it possible to fund living wages for peers. The late Sally Zinman devoted her last few years to creating a certification process for peers. She certainly did not do it just to have them be undervalued by low wages. Thank you.
Our next public comment is from Stacy. Your line is open.
Good morning, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. And I would just like to thank Lynn Rivas for her comments. I'm so pleased that CAMPRO is up and full strength, and they just had a wonderful conference in the Bay Area. And I just want to thank her for including everyone. I also would like to thank Commissioner Alvarez for doing an excellent job facilitating the CLCC meeting several days ago, and to commend Commissioner Rolette for attending and participating in the meeting. This shows genuine interest and commitment to reducing disparities for underserved communities, and I want people to know that representatives of BIPOC and LGBTQ communities do take note of these things. I would also like to give deep appreciation to Tom Orrick and Ryan Kopchak, the OAC staff, for reaching out to REMCO after the meeting to discuss some of the concerns that I raised during the meeting regarding the committee itself and the RFP process. I also, again, want to urge the commission on a different note to form a committee regarding the Innovation Partnerships Fund. However, I realize this is probably best commented under the last agenda item, so I will save my comments for then. Thank you.
Thank you, Stacy.
Our next public comment is from Sandy. Your line is open.
Morning, Commissioners. My name is Sandy Rives with Transitions Mental Health Association in Santa Barbara County. I'm a peer, a person with lived experience with a mental health condition. I'm also a family member of someone living with a mental health condition. And I'm here to talk about peer support as being an evidence-based practice for individuals living with mental health conditions. Peer support is invaluable because it lowers the overall cost of mental health services by reducing rehospitalization rates and days spent in inpatient services. Bottom line, it saves money. It also improves the quality of life and engagement with services of those living with mental health issues. It increases whole health management and self-management. As peer support workers, we are uniquely positioned to facilitate recovery through empathetic engagement with service users and their support networks. By sharing our lived experiences, we meet service users where they are at. We model coping strategies and provide hope and an example of recovery to those dealing with mental health conditions. California has finally recognized the value of peers by creating a state certification. Now I ask that you act by facilitating and advocating for a living wage for California peers, and that you dedicate 10% of non-Medi-Cal dollars to peer-run organizations in the state of California. Thank you.
Thank you, Sandy.
Our last public comment is from Damon. Your line is open.
First off, good morning, everyone, and I want to thank you for the opportunity to speak today. On behalf of CAMPRO, I am a advocacy coordinator, and I'm also a peer support specialist I'm new into this in this arena, and just want to just share a little bit of my experience as a peer support specialist, encountering trying to find a position that has a living wage. For me, it was very difficult to find a position that supported that had a wage that I could live off of. It's very difficult when you're in a position where you enjoy and love doing what you want to do, but you're challenged with the fact that you are faced with a wage that is not going to be supportive. And so I'm advocating for an increase of a living wage for peer support specialists and for peers for California, so we can provide a service that is for peers and in our community. Thank you.
Thank you, Damon.
That was our last public comment.
Thank you, Mariani. Thank you, everyone, for your comments. The commission will now move on to agenda item 4 and consider approval of the minutes from the July 25th, 2024 commission meeting. At this time, I would like to invite commissioners to offer comments or ask any questions. Seeing none in the room and seeing none online, I would ask that at this time, members of the public may request to make a public comment regarding agenda item 4 by clicking the raise hand button on your computer or the app, or calling in by phone by pushing *9. Mariani, are there any public comments regarding this agenda item? Please raise your hand now as the queue will be closing.
There are no public comments for this item.
Thank you, Mariani. Before I entertain a motion, I ask that all commissioners, both online or in person, unmute Airlines, I would entertain a motion that the commission approves the July 25th commission meeting minutes. Do I have a motion?
So moved.
Thank you, Commissioner Von Trigger. Do I have a second?
Second.
Thank you, Commissioner Robinson. I have a first and a second. I would ask Sandra that you please take.
Von Trigger. Brown.
Sorry about that. Aye for Brown.
Bunch. Carnivale.
Yes.
Carrillo. Chambers.
Yes.
Cortese. Gordon.
Aye.
Mitchell. Abstain. Robinson.
Aye.
Roulette.
Aye.
Vice Chair Alvarez. Aye. Irma Diaz.
Aye.
Motion passes.
Thank you. Let's move on to our next agenda item. Agenda item 5 is the consent calendar. This month's consent calendar includes the approval of 2 innovation programs for Orange County. The first request is to allow Orange County to join phase 2 of the Psychiatric Advanced Directives, Multi-County Collaborative. The second is a request for an extension for Orange County for their previously approved community program planning project. Both projects were shared with the Commission's community partners and listserv on July 18th and again on July 26th. 2 comments were received in response to Orange County's request to join the PADS Multi-County Collaborative. Commission staff forwarded both comments to the county and PADS contractor. A written response was provided for one of the comments received, and a phone conversation was had with the individual who left the second comment. The first comment received and the written response have been provided in your packets. As you remember, in May, Commissioner Roulette brought forward the recommendation that any innovation proposals brought forward to be considered on consent contain information on how the proposal aligns with the BHSA priorities, sustainability under the new BHSA funding areas, and consideration of the impact of the BHSA to existing programs. Both of Orange County's proposal outlines BHSA alignment and sustainability. Commission staff have sent the documents related to these projects to all commissioners, and a copy of the staff analysis for the proposals have been provided in your packet. As a reminder, any commissioner can remove an item from the consent calendar. That item would then be considered as a regularly scheduled agenda item at a future commission meeting. At this time, I would like to invite commissioners to offer comments or ask any questions.
I'd like to make a comment, because of potential, financial interests. I would like to recuse myself from this conversation and leave the room.
Thank you, Commissioner Chambers. Are there any other questions or comments regarding this agenda item? I see no hands raised or comments to be made in the room. I also see none to be made online from my colleagues. So I am going to move on to public comment regarding this agenda item. So now is the time that members of the public may request to make public comment on agenda item 5 by clicking the raised hand button on your computer or the app, or calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Also, please limit your comments to 3 minutes or less. Amadiani, are there any public comments either in the room or online? Please raise your hand now as the queue will be closing. Please open the line for comment on agenda item 5. Thank you, Amadiani.
We do not have any comments in the room, and we don't have any virtual comments either.
Okay, so now that public comments, we don't have any online or in the room, I would entertain a motion that the commission approve the consent calendar that includes the first, funding for Orange County to join phase 2 of the PADS Multi-County Collaborative Innovation Project. Are we gonna do these separately? Yeah. And 2, funding for Orange County's extension of the Community Program Planning Innovation Project. Do I have a motion?
So moved.
Thank you, Commissioner Rolette. And do I have a second?
Second.
Thank you, Commissioner Carnavale. I have a motion and a second. There were no questions or comments. Then Sandra, I would ask if you would please take the vote.
Bontrager,
Aye.
Brown,
I'm sorry, I keep getting muted here. Aye for Brown.
Bunch, Carnavale,
Aye.
Carrillo, Chambers, speak, Cortese, Gordon,
Aye.
Mitchell, Robinson,
Aye.
Roulette,
Aye.
Vice Chair Alvarez. Aye. Chair Maria Weiss.
Aye.
Motion passes.
Congratulations, Orange County. Motion passes. All right. Speeding right through, ahead of schedule. Okay. let's
Madam
do it.
Chair?
Yes, please.
Commissioner Brown here, just, sorry, I had technical issues trying to get on here and I missed your update, session, but I just was asked by, our MHSOAC researcher, Courtney Ackerman, to indicate that, I don't know if you made the announcement about the IVF, follow-up meeting that will be held in Lassen County. But there's been a date change on that. It's going to be, the 16th of September rather than the 12th. So just wanted to make sure that you were aware of that and that was published.
Thank you. We did make an update. And we will make sure that we have the dates posted correctly. Thank you, Commissioner Brown.
Thank you.
All right. Thank you, Mr. Chambers, for coming back into the room. We will continue to move on. We are now on agenda item 6. We will hear a presentation on full service partnership, funding needs, and the potential to use Mental Health Wellness Act funding to strengthen California's FSP programs. As you remember, in February, the commission approved setting aside $20 million in Mental Health Wellness Act funds to fortify the operations and impacts of full service partnerships. The passing of Prop 1 has placed new emphasis on the role of FSPs and strategies to measure and monitor their impact. The proposal we will now hear about is designed to strengthen California's FSP programs and better align incentives with outcomes to support the implementation of Prop 1 reforms. I would like to invite Melissa Martin-Muller, PhD, Chief of Research and Evaluation at the Commission, to present. Welcome, Melissa.
Thank you, Madam Chair. Thank you for the opportunity to present our more detailed game plan on a assistance and capacity building strategy for full service partnerships. Next slide. So as you are all aware, California has invested billions of dollars in full service partnerships since the passage of the Mental Health Services Act 20 years ago. And with the passage of Prop 1 validates their importance in the continuum of care. You've heard 2 presentations on FSPs over the last 15 months and have had opportunities to attend site visits of these important programs. By way of reminder, FSPs are meant to serve individuals who are unhoused or at risk of being unhoused and who have severe mental illnesses, often with a history of criminal justice involvement and repeat hospitalizations. Despite their immense potential to reduce homelessness, incarceration, and hospitalizations, FSPs continue to experience challenges meeting the growing need for services and operating as effectively within the broader continuum of care. In February of this year, the Commission, recognizing this immense opportunity, agreed to set aside $20 million in Mental Health Wellness Act funds to support a technical assistance and capacity building strategy for FSPs. At that time, staff indicated that we would come back with a game plan for how to allocate these dollars. I'm excited again to have the opportunity to present to you today on our proposal. In order to better understand the needs of providers and counties in the context of the state's goals, we conducted a range of community engagement efforts, including focus groups, listening sessions, interviews, research, site visits. We did the first of its kind statewide survey of FSP providers, and visited counties to do deep dives into their data infrastructure, their performance management, and other areas. Our last visit in LA County, just last month, we visited 2 FSP sites and had the opportunity to speak for almost 2 hours. Commissioner Chambers was with us on that visit, with 5 clients who were currently receiving services and who spoke just eloquently and wonderfully about their experience, really highlighting the potential of FSPs to change the trajectory of people's lives. FSP service providers and county behavioral health staff were clear in their need to receive supports in order to meet the new requirements under Prop 1. DHCS is currently in the process of establishing a center of excellence for evidence-based practices and service delivery models, including those that focus on FSPs. While these efforts promise to provide much needed support to counties in the implementation of effective service delivery models, there remains a lack of technical assistance and capacity building supports in these and other areas. So we found several strengths and several areas of opportunity that helped us craft our technical assistance game plan. So in terms of strengths, we learned that FSPs can be extremely effective at supporting people with serious mental illness. Their strengths stem from the flexibility and breadth of services offered. We also found that FSPs provide professional, compassionate services and vital assistance for people with the highest level of need, delivering a reduction in homelessness, hospitalization, and incarceration. For areas of opportunity, they were around strengthening data infrastructure, establishing new funding models, increasing the workforce available to serve individuals, increasing public awareness, access, and achieving more equitable outcomes. We believe if we can strengthen these core areas, we will see and we'll be able to meet Prop 1's goals of reducing homelessness, incarceration, and hospitalization. I also wanted to highlight that the areas that were lifted up through our community engagement efforts align with this figure and this vision for a strategic plan that McKinsey developed as part of their strategic plan for coordinated specialty care for first episode psychosis. You can see that the foundational levers at the bottom around funding, workforce, accountability, and infrastructure were exactly those same areas that we identified through our discussions with clients, providers, counties, others. Okay, as I mentioned, in February, the commission set aside 20 million from Mental Health Wellness Act funds to support these 4 areas. This is what we through our preliminary conversations and our research had identified as kind of four areas of potential investment. Today, we're bringing forward a proposal of 10 million focused on sustainable funding and infrastructure. The workforce and accountability domains are areas in which we need to have further collaboration and conversation with our other state agency partners, and particularly HCI and DHCS, to make sure that we're aligning our efforts and working in concert with one another. So our proposal today is to put forth a motion to approve a $10 million technical assistance and capacity building strategy that focuses on performance management and value-based contracting and improved service delivery. This would be a competitive bid process. We've identified, as you can see on the slide, some key areas for how the proposals would be scored and judged on. The 2 primary goals for this multi-year effort, so this would be 10 million over 4 years, are to first catalyze a restructuring of the current FSP funding system focusing on client outcomes as opposed to only billable services. This effort would incentivize county participation by subsidizing the transition to an outcomes-based model. And then secondly, to increase internal capacity of counties and FSP service providers through the creation and implementation of a work group or several work groups aimed at supporting counties in the implementation of evidence-based practices and CDEPs and other innovative solutions to support improved service delivery in FSPs. So that concludes my presentation, and now I'll open it up for questions and discussion.
This might seem like a basic question, but. Hear me. So Prop 1 implementation will have a huge emphasis on full service partnerships, which begins actually 2026, right? More in earnest. Can you talk through for me, how does that overlap work? This is over the next few years. How does that dovetail with those investments? Like, it's confusing. Will help me.
So the investments towards FSP in terms of MHSA dollars remain pretty stable. Of course, there's some additional money for housing and again, with DHCS establishing a center of excellence to support evidence-based practices, that will certainly help with technical assistance efforts. So the idea is that we see Prop 1 as being an opportunity to dovetail our efforts and align some of the work that we've already been doing to support FSPs to really support the agenda to reduce homelessness, incarceration, and hospitalization. So this is, I think, a targeted effort to support what the state is doing through all of its initiatives, including Prop 1, and including things like BH Connect. And I think what we've heard from providers and counties is that they're excited. They want to, help achieve these outcomes as well, but need some additional support.
You have another follow-up?
Go ahead.
Oh, no, it is pretty complex. I was, as you, Melissa, you noted, I was able to attend the site visits and also have developed over my long career FSP programs. So I'm really invested and excited about the evidence-based practices, the additional housing supports that, Prop 1 is going to bring. But just someone on the ground, and I hope that this technical assistance and whoever the competitive process we hire to support, most of the clinicians continue to talk about how it is one of the most effective programs in general. However, it is the most burdensome program on the staff. So I'm very interested in how we alleviate that, because I mean, like I noted, like I literally have clinicians that'll come to my company and like, I just have FSP because people are dying in these project-based housing sites. And so, but we know that if you get folks in, because I was able to listen to the consumers of FSP, it does work with housing supports and peer supports. So as we look at, and I'm just advocating for ensuring that we have that whatever DHCS is coming up with the evidence-based practices, that the counties can be able to retain the staff, get the staff to be able to implement that, and that there is some kind of value-based incentive for the staff and the system. Because if you're not gonna be able to incentivize the staff or the system, they're gonna still have the problem. So I'm just putting it on the record of what I know as somebody on the ground, boots on the ground. And just wanna highlight the importance of FSPs and peer support and workforce development. All the clients that I was able to see really had goals and dreams and hopes of what they would do. We talked about that. And a lot of folks were excited about peer support events, like some of them had actually went through the program, because you don't have to necessarily take the peer support program when you're ready to work. It's just planting the seed. But just that as we think about like these services that, don't forget that the peers are really core to helping things stick when the clinicians are not able to meet the client where they're at because they have a caseload. And yeah, I'm excited about the process, but I know that whoever we contract or they contract with, they're gonna have to be able to address the staffing and the burden issue of how burdensome this service is. Thank you.
Yeah, thank you for those comments. I just have a couple of quick responses. So one of the questions we asked clients or partners at that site visit was, how should the state be thinking about measuring success? And one of the first things that they talked about was no staff turnover.
Yeah.
Because of how critical it is to establish that trust and work with someone and have them be their champion and advocate and cheerleader and support. And then to have that staff leave is just absolutely devastating. So I think any workforce effort absolutely has to recognize how critical that relationship piece is and incentivize people who are really excited about doing this work to get them into the field and to keep them into the field. And so part of the decision around supporting workforce at this time was, we can already start the work without, contracting with outside consultants, and we can start working with HCI to help shape their specific strategies to support workforce and FSPs. Because we also heard from both sides the challenge of because this work is so field-based, the challenge of hiring staff and bringing them in. So clearly we need to incentivize and provide supports too.
And the new evidence-based practice guidelines that the state is gonna put on is.
Yeah. But all the partners that we talked to were super excited about the peer opportunities, and Commissioner Chambers was handing out her card and making those meetings.
Thank you, Commissioner Carnevale and John Traeger.
You go for the question.
I just went in line, so I'm not down to, okay? However you want to do it, please.
Yeah.
I mean, I think value-based purchasing, it's a conversation we have. I think it rotates every so often, so many years, but I mean, I think it's going to be critical for this to actually have any impact to get our counties on board early. They're really good at cost-based purchasing. We know how to do that in the public domain very well, right? But when it comes to paying for outcomes, that's really hard. So if there's a way that they can be participant on this on the front end, because we can devise the greatest plan, but if there's no adoption, it really didn't matter. So if there's a way that we could get them on the front end, and I think there are some examples in county land where this has happened, in child welfare wraparound, there has been an opportunity where they share savings with providers, et cetera. So I think there are some things we can amplify, but I think we really need to get the counties on board from the outset. So there's potential for adoption.
And there are some county pilots happening now, and we've gotten feedback that the work has been really already impactful. And so I think having those counties share out their lessons learned and implementation successes and challenges will be really important for bringing on other counties, creating that uptake.
I've lost control.
Well, so when the original full service partnership, the model, which predates the Mental Health Services Act, actually was a outcome-based finance model with employment as one of the outcomes. Actually, it wasn't outcome-based finance, outcome-based contract. The work that Commissioner Carnevale and Sheriff Brown and the chair participated in England, one of the models was incentive finance built into the contract for sort of staged outcomes. Housing, initial housing stability, employment, right down the line, with incentive payments built into the contract. And so Commissioner Bontrager, that is exactly the point of the 10 million investment, is to build the capacity with counties asking for it already, to design that. Also want to recognize that over the last 25 years or so, our behavioral health system has moved away from that strategy because of the emphasis on drawing down federal money. And so the challenge is going to be parsing the tensions between an outcome-based financing strategy and a federal drawdown strategy. And one of the things that we're needing to explore is a stronger understanding of the not just the return on investment for an individual or an FSP program, but how that impacts the broader state budget, including opportunities to reduce the number of people who are landing in state hospitals. During our recent visit, $300,000+ per year per person. And so it's about positioning FSPs in the context of the broader behavioral health system and recognizing that the potential billions in cost avoidance as to shift that tension between an outcome-based finance strategy and a fiscal incentive that is targeting drawdown of federal funds, because there are conflicting incentives or priorities around FSPs at the moment. And so we, for $10 million, we can't, dramatically rework this space, which is, an area where there are billions being spent. But the goal is to get started and to use the knowledge coming out of the counties and out of the providers with our peers and families, really thinking about how this should become, with early psychosis intervention, sort of the crown jewel of California's behavioral health system for folks who need a whatever it takes model to have stable housing with employment as a goal, avoid justice involvement, and avoid hospitalization, both community and state. The dollars are enormous.
They are enormous. I just think this is also an opportunity. It isn't just about cost avoidance. I think a part of this is to incentivize and create capacity amongst our providers, right? This idea that we're always having these providers deal in the realm of scarcity and expecting really positive results is a little absurd. And that actually speaks to the workforce issue too. When providers are dealing in a scarce scenario, they're not gonna be able to retain and attract the best. So I look forward to any opportunity where we can incentivize providers to be well and do well.
Madam Chair, I want to make a couple of comments and I want to make a recommendation. I agree with everything that's been said, and particularly Commissioner Bontrager, what you just said. I mean, when I first started in the commission, I didn't know what an FSP was. And when I learned what it was, and then I started explaining to other people who are not in the system what this was, it all makes sense to people that you can't just provide a piece of service like housing. You've got to provide whatever it takes to make somebody successful and thrive in life. So I've become very passionate about that and the various site visits. I've also, as a business person, I've become passionate about the outcome-based contracting, because to me, that's the only way that you should be doing contracting. It makes no sense to me. It makes no sense to me that the federal system is not designed that way, but that's, I guess, above our pay grade for today. So I'm fully in favor of this, and yet what you said is exactly right. We're constantly operating in this realm of scarcity with all of our initiatives, including FSPs and everything else we do. And I've become really passionate about the prevention and early intervention programs and the innovation work and everything else we're doing. So, one of the 4 levers that was mentioned in this program was sustainable financing. So I'm threading together a lot of work that I and we have been doing here on the commission, and I wanted to make a recommendation that I think could help address some of the scarcity. I'd like the commission and the staff to explore this idea of actually creating a center for sustainable financing in mental health. And I'd like to look at a more broad sweeping view of this, because outcome-based contracting is one of the pillars. Another pillar that I've talked about in the previous meeting is around making more investment capital available to all the public and private entities. There's the issue of catalyzing public and private partnerships to harness all the dollars that that are being spent to go into public services. And then I think the last piece, and maybe the biggest piece, is just the pricing and reimbursement itself. You know, what I've come to learn over the last month, and this is the big picture, is that mental health comprises about 16% of the disease of our healthcare system in terms of disease management, but it's only 2% of the budget. That's the differential here. And most commercial providers are reimbursing on average less than 20% of what's required to deliver these services. That to me is the core of the problem. And I think this commission has to start going after the core and doing whatever it takes to do whatever it takes. So I would recommend we explore that. And I don't know if that ends up coming out of this budget or a different part of the commission budget, but I think it's time we take this issue head on, because the sustainable financing underscores literally every piece of work we do. So I think it's a foundational element. So thank you, Minnie.
Commissioner Kleinbach.
I appreciated those comments. Just probably more of a technical question, just on your second to the last slide, one of the criteria for judging that the RFPs was strength of relationship. Can you elaborate on that a little bit? How's it measured? Just speak to that a little bit more.
Sure, I'm trying to go back to this.
I think it was the second to last slide on it.
Okay, yes. We're still working with our procurement officer to refine these, but the idea is that we want to acknowledge that there are that it's important to have established relationships in California with this community. And so we just, this was partially just an acknowledgement of existing relationships, partnerships, presence in California, understanding the relationship of FSPs within the larger continuum, that is an important component of a successful proposal to do this work.
Is that a more subjective criteria versus objective, or is that something that you think we'll be measuring, or
How
do you
we
judge
score
that?
it?
Yeah.
Yeah, the goal of having scoring components is to be objective. So that's part of what we want to work with our procurement officer to make sure that we have as much objectivity in how we score this. We'll also, when we do competitive procurements, we have we invite sort of not members of the immediate staffing team, but we invite others to weigh in and assist with the scoring. And so that can also help, you know, retain objectivity.
And if I could clarify, and the scoring rubric is made public as part of the process, so that all applicants know what the criteria are going in. So the criteria are not figured out in a closet, right? So you know, those standards are on the table, so that that mediates the subjectivity of it, in the sense that all of the applicants know what they will be assessed against, which then allows applicants to, often they'll build coalitions, right? If an applicant is interested, but they feel like they're weaker in a certain area, they'll often partner with someone who may be stronger in that area, right? So that the process is designed to mitigate the concern that the criteria are vague and subject to interpretation on the scoring team's part.
Commissioner Rowland, Vice Chair.
So I wanted to make sure that I disclose that the organization that I'm still Chief Executive Officer of is the unique privilege of operating the FSPs in 5 Central California counties, and have had an opportunity to engage staff around this project. And so my perspective around the 4 levers or the same, I agree that those are the primary measures, but one of the primary measures by which success, from my perspective, and again, it's somewhat siloed because we don't share data well. So what we do is we look at our own data and then we submit that and get feedback about our data. So that as a discrete outcome, data sharing is important. I think that it would be helpful for an FSP provider to understand and appreciate that how other providers are doing, especially in the same municipality, serving the same demographic. It would be very helpful. We don't do that very well. Secondly, and it's not organizational, I think it's throughout the state of California. Secondly, the notion of value-based payment. I know that we hear a lot from the state about moving to value-based payment. I think it's 2028 or 27. I'm skeptical because we are still focused on maximizing the federal Medicaid dollar, and this fee-for-service system that we're in really is based on scarcity. How little can I pay you to get the maximum amount of benefit? Not everywhere. There are some places, and again, those leaders in those municipalities know who they are, but it is based on that system. And it's that classic sort of fee-for-service model where we only get paid for providing certain types of service. And if that's not the service that you provide, how do you cover the essential costs that you believe are necessary to mitigate the dilemmas that the person is experiencing that may not be covered under Medicaid? That's another dilemma that FSPs experience all the time. Transportation. That's just one of those things that we talk about a lot. The other piece is just this workforce piece. How do you make behavioral health, especially behavioral health in the outpatient sort of the part of the system that is the contracted part of the system, which I'm a part of? How do you make behavioral health a career versus a transition spot? Because behavioral health, from my perspective, I've only been doing this for 43 years, so maybe I don't know as much as everybody. But I experience that many people come into behavioral health with a belief that this is a transition to an ultimate career, and that their position and role is not going to be something that they do for a extended period of their career. And part of the dilemma that was articulated by people who are receiving services and not being able to have the same case manager is that case manager comes into the work with an understanding that I'm going to do this for 6 months to 2 years, and then I'm going to transition. How does that impact the outcomes that FSPs are trying to achieve? And then my last point, and again, the first three are perspectives. For the commission to consider, we do need an articulated, this is an FSP, and this is how you evaluate an FSP, and this is what value-based care looks like in an FSP. That'd be helpful. Because I think that what you are hearing from the commission is just that we continue to sort of struggle with how we describe what is, I think it's 35%. Prop 1 is going to be dedicated to this notion of FSP. And what is an exemplary FSP? And what is a sustainable exemplary FSP practice? Or practices embedded in an FSP, better said. Some of those are defined by community, some of those are evidence-based, and then some of those are unique to the municipality, the area, the region that you live in. Because regions in California are different. The care that you provide in Los Angeles might be different than the care that you provide in Merced or in Stanislaus. That would be helpful, that articulated message. Thank you.
We're working on that last piece.
Yes, good. That would be
Toolkit
it would
for
be
implementation.
for full disclosure. That's part of where we struggle as a commission. How do we speak to that?
Yep.
But just a lot, and I hope you are working on this, and just to wrap my whole thought process. How do we leverage all this stuff after this project and the lessons learned to then take that to DHCS? Because as we keep saying, like, and what you're saying, like, I'm on those implementation calls. And they are promising to give guidance to the directors about what it means to draw down Medi-Cal to the best possible. I'm not, but that's the language. It's very ambiguous right now to our leaders. So if we are in that system of, and we're moving to, like, you're gonna try to draw down your federal dollar to the best, and you're telling people that, what does that look like in value? Is that the same thing? I don't even know if those are, and maybe it's my ignorance, are those the same things that the federals draw down in any kind of value-based system? Can those two work together in general?
I don't think it's an either or, but I think.
Like together?
Yeah.
Okay.
I mean, it's complex, but I think any sustainable financing strategy has to acknowledge both the federal dollar drawdown as well as incentives that can be mapped on top of that to support things like transportation and other services that aren't billable and
That would-
reimbursed through Medi-Cal.
I just want to acknowledge that Vice Chair Alvarez wanted to make a comment, and so did the Commissioner.
Well, my comment sort of builds on both Commissioner Rowland and Commissioner Chambers, in a little bit more. There's a lot of like parallel conversations in the traditional physical health world, right? And you're talking about enhanced care management, and you're talking about population-based models. Like, and I'm encouraged by what these models ultimately do is keep the client, keep the person front and center. Like, whatever that person needs to be their healthiest, that's what we want to do. Get the system to figure it out, right? So I'm encouraged by that piece. But I would love to know a little bit more, building on your comments, in particular, Commissioner Rowland. I mentioned earlier that we visited the Urban Restoration Counseling Center, and that they have a strong relationship with the doula program. In my mind, for that Black birthing person, the Urban Restoration Counseling Center could be an FSP in that it connects them with housing services, because they need a housing voucher, because now they don't know where to go. Domestic violence services, because her partner is in, am I understanding that right? And would it be identifying how to support that center and becoming an FSP because of these 4 elements that we will identify? So that's like one question. And then my other question is, we know that in certain counties, roughly half of FSP is going to kids, going to young people, right? Particularly LA County, almost half of dollars are going to youth families because of the risk for homes or being unhoused, excuse me. So how then are these dollars going to track that investment will continue? Where is the accountability to ensure that those most in need of FSPs, is there an opportunity for the Center of Excellence or for our technical assistance to ensure that those data points are being continued to be followed and prioritized? Those are 2 big questions.
Well, let's see. The question about whether certain agencies or organizations could become an FSP, I think does come down to how we articulate the eligibility criteria for who can be served in either a child, transitional age youth, or adult FSP. But when you're talking about the doula program and services for domestic survivors or victims of domestic violence, I mean, I think the other way to think of it is that this whatever it takes model, like the FSP service is the kind of home for the partner or client, but I mean, caseworkers are working through their incredible networks, their housing networks, their other community support networks, employment networks, social activity networks. So I think linking partners to the services that are most going to change their trajectory and support their recovery, that's already happening. I'll have to get back to you on sort of what it would take for a current agency to become eligible to receive FSP dollars.
What about the tracking of, like, we know, again, half of LA County dollars are going to children and families at risk of becoming unhoused because of possible youth. how are we gonna track that, those high priority areas that we know, require such an investment in these resources? What does that look like? Or potentially, look like? Because these are all big questions that we don't know, right?
Yeah.
These are big questions. These are the right questions. The origin story of full service partnerships is very different from the scenario you laid out. Right, the origin story was the state was housing people for years in locked state mental hospitals at just tremendous cost. And there was not a community-based alternative at the time. And so full service partnerships were developed as a strategy to support people who otherwise would have been served in a locked facility. Right, very different origin story from the scenario that you laid out. And so that's why the original goals were around reducing hospitalization. Meant that the vast majority of people were placed in locked state mental hospitals with criminal justice involvement. And so reducing criminal justice involvement was a secondary goal. And that criminal justice involvement also often came about because they were unhoused. So reducing the number of people who are unhoused was the third primary goal. There's more to that story, but generally this was about providing a level of service that did not previously exist for people for whom we had no alternative but to have them in an institutional care, knowing that that was inappropriate for lots of reasons. And it was designed as a challenge to a community provider in Los Angeles County which is why it's called a full service partnership. You can do whatever it takes, right? And the money was exactly what Commissioner Bontrager lays out is, give us cash, but allow us to do what we need to do to be successful and evaluate us on the outcomes, right? As opposed to an aggressive compliance and audit function relative to sort of drawing down federal money. Are you doing what Medi-Cal pays for versus doing what the client needs? The pressures that counties face to draw down federal money have sort of shifted the pendulum away from the user experience driven program design to a reimbursement driven program design. And that has created the tensions around what we can pay staff, right? It has created, and again, it is because of a resource scarcity environment, which means we're, and we've moved back. I would argue we've moved back to the bad old days, as evidenced by the increase of $1 billion a year that we're investing in state hospitals to respond to people who are deemed competent to stand trial. Back on the streets, back in the justice system, back in state hospitals at enormous cost, right? There's also a recognition that we don't have what some people refer to as step-down care or an FSP light. Not that lends itself more to opportunities for individuals to transition out of an FSP and to support people so that their needs don't escalate to the level that they would need an FSP. Meaning they can manage their housing, but they need some support versus the higher level of support. The commission's work on early psychosis, and so Melissa put up the slide of that upstream work. Our focus on school mental health, all COBIA's drop-in programs, early psychosis intervention, those are all upstream strategies intended to take pressure off of our full service partnership systems, which are then designed to take pressure off of our hospitals, our jails, and the streets in terms of being the only alternative to folks who have significant needs, right? And so, but we recognize that while we have developed an ALCOVE model that targets transition age youth as a drop-in integrated primary health care and primary mental health, behavioral health care, we haven't done something comparable for people who are not transition age youth, right? And so Melissa's comment about in that graphic around the ecosystem design is that we're not necessarily suggesting that full service partnerships are the be all end all. It's the idea of how do we design a system that we aren't relying on a full service partnership, because we can build more outcome-based strategies into the broader service delivery system. Full service partnerships are not necessarily the goal. They're often an intensive level of care for a couple of years, maybe longer. But the idea is, if we have supported that person through peer strategies, that we can help to transition them into independent living. Again, the original goals is a job. And with a job, purpose and hope and health insurance and enough money to pay for housing. That is not the goal today.
Yeah, I do.
Oh, go ahead. So, given that eloquent historical narrative to help us understand the history, so how do we get to where we can stay at outcome-based services, where we're not chasing fee-for-service outcomes that are consistent? I just want to know, that's one question. And then in the presentation where you did speak of improved public awareness, what public are we talking about? I mean, I truly want to know, are we talking county public awareness? The end user public awareness in your findings?
All of the above, that individuals or family members would know that this service exists and where they can receive help, that within a county system, that referral sources know where to refer to and what services they're gonna provide. I think Commissioner Carnavale mentioned before he started on the commission, he'd not heard of a full service partnership, and I think that that's a common thing. You know, they're not well known to the general public, and not even for those of us who work within these systems. So I think raising the awareness in the context of that broader continuum.
I also think that, can I just say one thing, that model that you talked about with the upstream and downstream. I really appreciate the historical reference, because if I would just look at it black and white, I can also understand you get an FSP only if you're identified as being very expensive. Right, I'm just being really like, if you're identified as costing our system more, then we're gonna meet all your needs. Because I can argue that a new mom who is postpartum depression also deserves to have all of her needs met, right? Just the concept of that model. And, but I'm gonna accept, right? I'm gonna accept like that we want to invest in FSPs for folks that are at risk of incarceration or being unhoused. But I like what you said about, so then what does it look like to go upstream? And I want to say this out loud to our commission, that we start at school. This graphic starts at school. And we know that early childhood trauma, adverse childhood experiences is what is causing billions, I'm talking about cost avoidance, in mental health crises and economic crises, all of the things down the line. So again, just as a reminder to the commission, we will hear more about what we can do moving upstream and hopefully update your graphics.
Can I just make a point to that point, because this is all about sustainable financing. But, you know, some people are gonna hear this as, oh, they want to spend a bunch more money that we don't have, and that's not what this is. If we design the systems right, which are around prevention and early intervention, they save money over and over again and serve people. We can have our cake and eat it too. That's what the psychosis report just showed with McKinsey. Today, we're serving less than 10% of the psychosis patients. We can go to 90% and actually save money. We just aren't building our systems to do this. That's what we've got to do.
Please, Commissioner Chambers.
So my understanding and appreciation from the early days of being around the second iteration of early FSPs that were more value-based that dependence on specialty mental health care was not the goal. The goal was not for people to be in FSPs for the totality of their lives. From a population health management perspective, I appreciate it as I'm going to help people understand and how to utilize their Medi-Cal benefit more effectively. And that includes early intervention strategies. That includes the birthing person that goes to the project that you described. How do I use my Medi-Cal benefit more effectively? And that organization that you visited, if they're an FSP, one of the goals is to help teach and help that person appreciate how to use that benefit so that they don't have to come back to an FSP or an urgent care setting to get their healthcare or behavioral healthcare needs met. The pendulum has swung away from that. We don't get paid to do that, in my opinion. What we get paid to do is to do the big four levers. And what's implied there is keep people in FSPs to ensure that those things don't happen, the adverse effects happen. So we've got to shift it back. And as Toby has indicated, in my opinion, pay organizations, reimburse organizations to do the kinds of things that really do result in people ultimately realizing this is the true benefit of my Medi-Cal. This is what I can do in order to address the dilemmas early on for my children and for myself as a youth and for myself as a young adult and as an adult. But we're not there.
Commissioner Chambers.
I'll be really quick. This is a great conversation and I geek out on this. But to your point, Commissioner Alvarez, I honestly don't think that person you described, like Toby said, is gonna ever, or the provider. I mean, I'm probably gonna have hard challenges ever providing the services because of the contracting challenges that with our managed care, some of our managed care plans, and then as it's just hard. Like as someone that's on the ground, like I try to get somebody in care. It was very complex and I don't know, and my niece is in FSP. And to your point about letting the family know, I couldn't get any information. She didn't even understand she was in the FSP program. So I don't know, I'm a user as a family member but I know that it works for some people, but I don't know how people get into it, or I'm honestly being honest, or really even get help a woman that's going through psychosis like me after having a baby. I think I had to call a couple of people on the commission to try to get some real help. So I don't know where to actually send people at, just somebody that if they call my number, like I could give them the county line, but I don't know, they might trip out and go to the hospital by the time they go get help for that psychosis, like myself. And then just to the point of like investments, I think it's a broader question. Like the new law says that our MHSA dollars are gonna be mostly concentrated in these areas with the most severe people, the most sick. So that is already our approach and that's already in the bag. And the most severe individuals will probably get that other housing budget too, money. So I think that a lot of our money is gonna be concentrated for a subset of people. So even like that woman that's struggling with psychosis that probably needs housing, I hope she could get housing, but if we're focused on keeping people out of jail and keep them up, I don't know how much support that woman is gonna be able to get in this new system or being able to go contact even the health plans to get help, because I've been trying to contact the health plans for community supports at ECM to help women. I have not been able to get in contact with them. So to the point, I think it's how are we gonna talk about what's the real priority? The priorities are they keeping people, like, are they keeping people from getting out of these higher levels of care? Like, and where are the access points that we can actually even refer someone to before they do it, even like myself, like as someone that was going through psychosis and after having a baby and has health insurance and still needed to contact other people. They wouldn't have, and I was at risk, pretty bad.
Thank you, Commissioner Chambers. I have Commissioner Brown who's wanting to say something.
Thank you, Madam Chair. I just wanted to echo some of my fellow commissioners' comments, particularly Commissioner Carnevale's and Roulette's. I see this proposal that's in front of us as a step to leverage existing FSPs or prospective FSP resources as we start to provide the technical assistance and do these additional support measures. But as we transition from the successes that we've seen with FSPs and those that we anticipate that will come as a result of this recommendation and the implementation of Prop 1, all of that, I think we have to realize needs to be juxtaposed alongside the need for really good strategic planning to achieve scale and to achieve that long-term sustainability that is going to be so necessary with something of this magnitude, a change of the magnitude that's really underway with Prop 1. So those are just my thoughts. I just wanted to add.
Thank you, Commissioner Brown. Other comments, questions?
I just, it's complex, it's exceedingly complex, and I just wish whatever we do creates easy access for individuals like Commissioner Chambers, because we get those phone calls as prior clients of the system who have successfully navigated for our loved ones. But it's not without a lot of work. And it's literally, the earlier you come into the system, the greater opportunity you have for success. Because coming in as a teen, and heaven forbid, as an adult with a severe mental illness or whatever these other mental health challenges are, it's just too hard to get the help that you need because there's no consistent door for you to go through. And every time I get a phone call, I have to feel really bad that I can't tell people to do one thing that will get them at least started. If their kid or loved one is not coming through law enforcement, that's crazy.
Right, shouldn't have to be that way.
And we are the system. We've got to figure it out because it's just too much suffering. We gotta figure it out. A one stop, one process, one procedure, one phone call that can get you on the path to wellness. We gotta figure it out.
Right, thank you, Commissioner Mitchell. It's. We shouldn't have to continue to hit the boxes to get the care that we need. Right? It doesn't have to be extreme. It's kind of like, in order to see a pediatrician when I was young, you had to hit all the right. My mom would be like, yes, you have a fever. Yes, you have this. Yes, tell them it's been hurting, but it hurts really bad. Just to get in to see, right? You had to keep hitting the boxes. And so why can't we just make those calls and not have to keep hitting it until we get it right to be able to get seen and get the care that we need? And I appreciate the comments on FSP Lite. What does that look like? Why does it have to be all? I'm also curious, and this is a question. And I don't know if I'm using the right language. What is the recidivism rate for FSP? Is it once you go into FSP, is it and what if you need it again? What does that look like? And maybe recidivism isn't the right word, but is that back to the data question? We're not really keeping great.
Absolutely, and in fact, Melissa and her team identified a drop off of like 20,000 clients, from year 1 to year 2, and there are tremendous problems in the data system. The state is in the process, the HCS is in the process of redesigning its data system. That's one of the elements that we hope to come back to you with in terms of, again, you asked to set aside $20 million. Today on the agenda is $10 million on the finance side. We were not able to do the homework with the Department of Healthcare Services to understand the work they're doing around new data systems. But our team has been mapping FSP data, so clients in full service partnerships against criminal justice data so that we could understand positive versus negative outcomes. And so, one expression of recidivism, so to speak, is not just leaving an FSP and then returning, but it is justice involvement, right? In conversations with the California Hospital Association, there's tremendous frustration that they actually don't know who's in a full service partnership when someone lands in their emergency department. And so there are lots of challenges in terms of understanding, communication, coordination, data analytics. And so more to come, because this is a bigger set of challenges than we can address with the funds that we have today. But the goal is to get started. The goal is to coordinate with our counterparts in the Department of Healthcare Services, Healthcare Access and Information, who has the workforce dollars, the Health and Human Services Agency, who will be designing the accountability system, which includes reporting around finance, working with the Department of State Hospitals. Some of their research shows that less than half of the clients who were referred to them with an incompetent to stand trial designation, often psychosis and a felony charge, less than half actually received community services 6 months prior to their arrest or their judicial declaration, right? So big lift, $10 million. The ask is to get started.
I would also, okay, I just wanted to chime in that in November, we have our next biennial report to the legislature due. So we'll be coming back with more information on things like average length of stay, recidivism, what we know from the data, even though it's not perfect or complete and has challenges, we can share what we do know about some of these questions you're asking.
I also want to come back to what Commissioner Connor Raleigh was talking about, and I don't know if that would fall within this, but I would like to see a proposal on, we talked about scarcity over and over, it was scarcity of the dollars, right, and what we're talking about. So a proposal to really, work with staff to identify some strategies, best practices, whatever that might look like, but around sustainable funding. And so we've talked about the private-public partnerships, but we can't be having these conversations and building a model again around scarcity, and we need better ideas. So if you could work with staff to do that, I would appreciate that.
I'd be happy to do that. Thank you, Madam Chair.
Thank you. Thank you.
Okay, process question. Just with like Prop 1 implementation, are we expecting any updated guidance or regulations on FSPs?
Yes. So the department, as some of the comments that were mentioned, the Department of Healthcare Services has new authority to establish standards around early intervention. And that's right.
We all are.
And evidence-based practice. There's a whole series of opportunities for the state to take a more facilitating role in workforce prevention, early intervention, full service partnerships, finance. So and that touches upon FSPs in a number of ways, including opportunities to support people so they don't need an FSP. So we're talking with the administration about how best to engage them and hear from them about their vision and the opportunities that will be rolling out over the next 6, 12, 18, 24 months, and then even further. And as of yesterday, they've asked if they could come and present on early intervention next month. And so we're actually wanting to give you lots of opportunities to ask these questions and to provide guidance in response to the opportunities.
Any other questions or comments about this? Okay, seeing none, I want to I would like to move on to public comments regarding this agenda item. So, Mariani, if you could please open the line. Please raise your hand now as the queue will be closing. Do we have any public comments?
Yes, we are receiving the few online. We do not have any in the room. We currently have 2 virtual comments. Our first comment is from Claire. Your line is open.
Hi, thank you so much. Hopefully my video went on. My name is Claire Courtright. I'm the policy director with Cal Voices. And I just wanted to start by really thanking Commissioner Ewing for that history on FSPs. I thought that was incredibly helpful and really says what the tensions are. And I would like to also link it to some of the comments about peer support. Currently, in the regulations for FSPs, one of the things called out as being part of the full spectrum of community services and supports is peer support. And I know the commission is aware that because of the funding structure under SB 803 for peer support and all of the new mandates in BHSA, that peer support could be facing some real problems in remaining a service that is funded under the MHSA. And so, in keeping with what Commissioner Ewing was saying about all these tensions, right? I mean, full service partnerships was supposed to give the flexibility to do whatever it takes. And so that's not necessarily like a pre-planned menu of services. And I think that's one of the places where including peer support and making sure that it's a mandate in the new FSP regulations lets you maintain that flexibility. And I've done this as a peer support worker in a crisis residential setting where, I was billing Medi-Cal for my time, but it was also MHSA funded. So there was a lot of flexibility. So we have these folks that are like really in crisis and they need more face time. They need more support than what they can get out of their case manager. And being able to, be in a residential setting, but also be, have some of that flexibility that, MHSA or BHSA non-insurance funding allows you to do, really literally help me have a wider scope of practice and be there for folks in a way that got them out of crisis when the sort of traditional models or the Medi-Cal funded stuff wasn't sufficient to support that person. And so I just really want to uphold peer support as a way within an FSP model where you're trying to have greater consistency and accountability to also maintain some of that original virtue around doing whatever it takes. And peer support with a full scope of practice is a way to do that. So hopefully that wasn't too garbled. And then I just wanted to make one comment about goals and criminal justice involvement, because it's something that bothers me, which is that I really think the state needs to disambiguate the criminal justice system from the civil side of the house, because we don't have to charge people with crimes, right? And felonies sound scary, but it can be picking up a feather on the beach. Our folks are targeted for criminalization. That's a choice that we're making on one side of the house that we just don't even have to make at all. So this idea that, passive voice and our folks are stuck in the criminal justice system and they're stuck in misdemeanor IST, it's a choice. It's a choice we don't have to make. So if you want to deal with criminalization, you can do that completely independently of marrying it to the civil side of the house.
Thank you,
Thanks so much.
Claire. Your time is up. Thanks.
Thank you, Claire.
Our next public comment is from Steve Leone. Your line is open. Steve, your line.
All right, can you hear me now? I was trying to unmute.
Yes, Steve, we can hear you. Go ahead, please.
Go, thank you. First of all, I wanted to thank your materials, whoever put together the materials, the background materials are very good. And also, I salute Toby. You're saying so many of the things that I have felt rather desperate over the last year and a half as this has been going through, and often feeling like people are not getting what I'm trying to say. And you said a lot of it today to your commission, so thank you. Moving ahead, I have 2 quick comments, hopefully quick. One is that on the selection strategy for that you'll be moving for funding, It says proposals will be judged on. You have 7 things listed. And I'm not sure I'm adding to that list so much as adding at least to what you'll be looking for behind the scenes. And that is, first of all, an understanding of recovery as it is seen by clients themselves. And to quote the materials here, building rather than fixing is one way to put that. And I mean, a lot of people regard recovery as give you the right meds and you're better, and that's recovery. And it's not fixing, it's about building up the person and helping them to navigate their issues. Secondarily, you talk about familiarity with California's behavioral health systems. I would suggest that you would make sure that this familiarity includes with such things as psychosocial rehabilitation, is one of the core values of the original FSP, as described to you by Dave Polan some meetings ago, and that they keep that in mind and not simply being familiar with the fixing part of the system. So I could say much more, but I kind of want to keep it limited so you can digest what I said. Thank you so much.
Thank you, Steve.
We received one more public comment from Steve McNally. Your line is open.
Thank you. My name's Steve McNally. I'm a family member of some with schizophrenia. All his relationships are restored. His family relationships. And I'm a member of a county board. My comments are my own. I love the presentation today and the interaction between the commissioners. I would hope when Department of Healthcare Services comes to you next month, that you get the presentation ahead of time, read it, and spend your time talking about it, because we have so much talent in the room. And for me, I just see a lot of presentations across state where so much time gets eroded by presenting information that can be read, and then the value in the room never gets heard, either publicly, and it encourages backroom dealing. Commissioner Carnevale, thank you very much for pointing out the budget. That's something we struggle with, particularly between the Medi-Cal reimbursement rates versus private insurance, and how private insurance seems to be able to walk away from the schools, walk away from any serious mental illness. Commissioner Rolette, thank you very much. I think trust can be measured in linkages, because the FSPs that can motivate better can link people more. And at least in our county, I think it's in most places, they have 100% referral rights to anything in the county. And I think we might want to consider paying someone extra money to be the super navigator across everything as like an additional fee. Emory Cowan up in Solano has a 2-tiered workforce program, so that if I'm disabled and I can't really work like my son, I might be able to find mission and purpose. Not everybody who's in a county mental health plan will be able to work. And I think we need to find the lanes. Where does county mental health fit versus Medi-Cal, mild and moderate? Because the ECM, enhanced care management, and FSP seem to be similar. And at some point, people may move from one into the other and back. And so there's so much to cover. And I guess the last thing, because I don't see a clock, but I know it's going to be coming up, is I think we need to have a 2-tiered, you've probably seen them, where one line is urgency, another line is effectiveness, and we want to get into the quadrant at the top that's urgent and effective. We're not, unlicensed workforces, I think, where we need to get to, and yet we certified it. Now we're making it really hard to get it billable. And Department of Healthcare Services is not making it easy for providers to get on board.
Thank you, Steve. Your time is up. Please wrap up.
I will follow up and I will end. I think you need to look into this. It's taking 24 months to get certain people through the system. become providers. Thank you very much.
Thank you, Steve.
That was our last public comment.
Thank you, Amariani. So at this time, we had no questions or other additional comments from commissioners. I would entertain a motion then that the commission approve the allocation of 10 million in Mental Health Wellness Act funds to support the capacity building and technical assistance efforts as specified in the enclosed FSP funding proposal. Do I have a motion?
I'll move it with the comment.
Please, Commissioner Rowland.
Would be intriguing to appreciate how the component of enhanced care management could be incorporated into an FSP-like type service. Now, again, it just said a whole lot in very few words, but that's an intriguing notion. So I still move it, but I wanted to, when the Steve said that, I was intrigued by that.
Thank you, Commissioner Rowland. So we have a motion, an intriguing comment that we've taken note of. Thank you, Commissioner Rowland. And do we have a second? Thank you. We have a motion and a second from Vice Chair Alvarez. I would ask now, Sandra, that you please take vote.
Bontrager.
Aye.
Brown.
Aye.
Sledge. Carnivale.
Aye.
Rio. Chambers. Cortese. Gordon.
Aye.
Mitchell. Robinson.
Aye.
Roulette.
Aye.
Vice Chair Alvarez. Aye. Chair Weiss.
Aye.
Motion passes.
Excellent, thank you. I would at this time just like to, I want to welcome Jenny Bayardo, Executive Director of California's Behavioral Health Planning Council. She has joined us and is in the room. Thank you and welcome. Happy to have you here. And at this time, we are going to take a 10-minute stretch break. So everyone, 10 minutes, we'll come back. So if we can have Lester, if you want to mute the mic, we're going to take a 10-minute stretch break. We'll see you back here in 10 minutes. Welcome back, everyone. For agenda item 7, we will hear an overview of the work to support school mental health, including an update on a legislatively mandated report on the implementation of the Mental Health Student Services Act, or the MHSSA. We will also hear about the recent MHSSA request for applications, how the commission supported the MHSSA technical assistance teams, and the potential for new investments in supporting school mental health. We will also hear from a local MHSSA grant partner, Descanso Elementary Hope Squad, and students participating in the program. Hope Squad is an evidence-based suicide prevention and mental well-being peer support program. At this time, I'd like to invite Dr. Melissa Martin-Muller, Chief of Research and Evaluation, and Ryan Kopchak, Chief of Community Engagement and Grants, to begin our conversation. Hand it over to you.
Thank you, Madam Chair. We have slide deck. So while that's loading, I'll just start by talking about the incredible investments that California has already made for school mental health. We also have a premium on school mental health within this commission. We have 2 commissioner seats dedicated to education. And through our PEI work, there's a stipulation that school failure is one of the 7 negative outcomes we should collectively work towards mitigating. As our chair indicated, my role in the presentation today is to provide an overview of the executive summary that's part of the report to the legislature. This is a first read and a chance for you to provide input and comments on our findings and recommendations. Okay, so the snapshot is for the Mental Health Student Services Act is that we've currently made 255 million in investments. I think now it's 280 with the latest round of funding. The grants have gone out to 57 of the 58 counties and to city municipalities. Only Alpine County is the one county that does not receive MHSSA funds, and that's due to the county size and just the geography is such that students cross the border over into Nevada to attend school. The MHSSA prioritizes the highest needs K through 12 school districts and schools. It represents nearly half of the districts and about a quarter of the schools. Services are also tailored to match local needs and to address disparities. So there's not a one size fits all formula for MHSSA. And in fact, one of our key learnings, which I'll talk about in a couple minutes, is just that the services and supports and ways of using the funds is very heterogeneous across the state. I'll just share this quick infographic kind of summarizing some of the key data points that I just discussed. So some of this data on the number of students served is through reporting from our grantee partners. And we have identified that one of the areas of technical assistance really is around data collection and reporting. So one of our key TA components is around the data and reporting piece. Okay, so we've seen some implementation successes with MHSSA. We know that these grant funds have deepened partnerships at the local level. This has allowed for more seamless referrals between schools, districts, and county behavioral health. We know that it has expanded the continuum of mental health services in schools. Some of our grantees have hired mental health professionals or clinicians to support the entire school or to add clinical staff to their existing infrastructure. There's been an increased awareness and destigmatization of mental health through these dollars. A lot of grantee partners have used these funds for suicide awareness and prevention, for teacher and staff training, for other social emotional curricula. And these efforts have really shown and demonstrated an increased awareness and destigmatization. Services are also making a difference and engaging and educating parents and caregivers. We've done listening sessions and focus groups with parents and caregivers and have heard firsthand what a difference it's made for their students to know that there's a trusted adult that they can go to at their school to support their emotional well-being as well as their academic achievement. We've also have some key lessons learned. Again, the services and supports really were meant to be tailored to the local need. Grantees were able to identify their county or district priorities and build their implementation strategies around addressing gaps in services, addressing disparities, and really, again, prioritizing highest needs within the county. We also know that the need for school-based or school-linked mental health services often does exceed local capacity and requires additional funding and sustainability planning. These first 4 rounds of MHSSA funding were really meant to support the partnership development and not meant to be, a population-based funding strategy for the entire state. We know, of course, that mental health professional shortages continue to impact access to and provision of mental health services. The story is no different for school mental health. We've learned from grant partners that they really want technical assistance and have identified key grantee partners who are able to be peer technical assistance partners, as well as identifying key experts and people across the state who can provide that technical assistance as well. We've also uncovered that really need to establish school mental health standards so that everyone, parents, teachers, students, staff, educators, leaders, can really understand how we're doing and where we need to continue to invest to reduce disparities and achieve educational and well-being equity across the state. And then lastly, for lessons learned, we need to align all these various school mental health initiatives and projects that we're all working towards the same goal. We're all doing slightly different pieces of the puzzle. So to really try to align those puzzle pieces so that we can work strategically and efficiently towards supporting school and student mental health. So through these lessons learned and conversations with grantees and again, focus groups with students and teachers and through our youth advocacy work, we've kind of lifted up 3 key recommendations that we'd like to put in our report to the legislature. And we think that these are really the next steps. These aren't do these and then we fixed everything, but if we continue down this incredible path and journey that we've started, we think that this will help push the field along and are the next important steps. So first, leadership. We know from implementation science that establishing a champion and a lead is so important for being able to be successful. So we recommend establishing an office of school mental health or center of excellence for school mental health to really support putting together these puzzle pieces. The second recommendation is to continue investing in school mental health. As we heard from the last presentation on full service partnerships, sustainable funding, not just one-time injection of dollars, it's really what it's going to take to be able to support our youth and students in the long run. And then third, we need to have an accountability structure, including standards and metrics to look at whether we're making progress towards those particular standards. So this could look like a report card that goes out to the public so that parents, teachers, students, again, can look to see how's my school doing? How's my district doing? How's my county doing? And what do I need to ask for if my school or district or county is not meeting those standards as well as they could? So next steps for the evaluation and for the report to the legislature and some of our other commission efforts. Ryan's going to talk about the latest round of funding for MHSSA, so I'll let her do that. We are also, she'll speak to implementation of a statewide school mental health technical assistance strategy. We've just completed our planning phase of the statewide evaluation and are ready to move on to actually, working on phase 2 and doing case studies and other kinds of quantitative analyses to tell a statewide story of the impact that MHSSA has had. We're working on finalizing and I think are bringing to the commission in September our report to the legislature on universal mental health screening as one of the core components of a comprehensive school mental health system. And then lastly, we're continuing to hold community engagement activities and events to hear from parents, educators, teachers, students themselves, to really listen and hear what is important in terms of a standard, what is important in terms of what we're measuring. What we treasure is what we measure. Our chair said right before this presentation. So with, and the report, the full report to the legislature, I also just wanted to mention, not only will have some more detail and a little more connective tissue between our findings and lessons learned and recommendations, but we're also really excited to include some county spotlights. We've have San Diego and Sacramento represented in our county spotlight for the report, as well as other counties who are just doing amazing work to implement MHSSA, to support teachers and students and schools. So we're really excited to be able to present our larger and more colorful report next month. So this was a sneak peek, and we look forward to your comments and input. And with that, I will turn it over to Heather.
Okay, you. All right, well, thank you for having me. I'm Heather Namor, coordinator for student wellness and school culture here at San Diego County Office of Education. And I'm here to talk about our MHSSA grant, which is, oh, the slides. Oh, do you need to do, oh, yeah, I can click. Where do I click? This is very
No, I was
futuristic looking. Okay. I know. There we go. Okay, well, okay, great. So I'm here to talk about our MHSSA grant, which is called Creating Opportunities for Preventing and Eliminating Suicide. You'll be hearing me say COPE, and that's the acronym for that. And so in hearing this report, really putting this presentation into the context of that, our county decided to choose probably a little bit of a unique model with our grant funding, and that was to not really put the funding towards mental health professionals in schools, but rather build the capacity of our charters and districts so that this work can be sustainable. And so I'm going to talk about how we have done that. And if I refer to an acronym, LEA, it means Lead Educational Agency. So we have, as you can see here, 15 school districts and 16 charters that have been a part of this 4-year journey. We are halfway through. We're about to enter our 3rd school year with this grant. And these LEAs represent over 430 schools, with one of them being Descanso, and over 290,000 students. So the model is really to build liaisons within each LEA that's a part of this grant to really be able to champion mental health, create communities of care within our schools, and also be able to have suicide prevention subject matter experts within each LEA. And so this work has really been an ongoing process, and it kind of, I thought that was me, that green bar there. And it has these 3 overarching grant goals and objectives. So the first column you see, suicide prevention, intervention, and postvention. It has really taken the first 2 years of this grant to build the foundation to really take suicide prevention policies and put them into practice. So they really inform our daily work with students in the schools. And it involved a lot of work around data collection and so forth, which I'll talk about in a minute. The second one is just mental health promotion and stigma reduction. And this is really about lots of trainings, lots of sharing resources that meet the unique needs of each of our districts and charters. It's student programming, which you'll hear about, and also touching on, of course, staff and caregiver wellness. And then lastly, our school mental health referral pathways is something we just started to work on. And we did a pilot in the spring with 1 district, 1 charter. And what this involves is creating an internal resource countywide map. And it allowed us to resource map all of the mental health trending tiered supports that are available countywide. And working with each LEA in the pilot, we did resource mapping within their own LEA, did a gap analysis, and then we're able to fill the gaps. So they have a comprehensive referral pathway in each of their district and charter schools. So we're really excited because we're really going to start doing this work the next 2 years with the other LEAs in the grant. Everything we do is data driven. We are very much in the beginning of the grant. We wrote in an evaluation piece. We have a team of evaluators at UCSF that partner with us on this work. Every year, we do a comprehensive needs assessment with each LEA that's a part of this, and this really allows us to see where are we moving the needle? Where are there growth opportunities and areas that we can focus on with each LEA? And then overall, what is the COPES needs assessment data saying as far as larger trends? So this really drives our work year to year. And then we do not have our latest data, but I wanted to share this with you. So we have a second year annual brief that's in your packet. You can see a lot of the areas where we've made some growth and impact. We are working on our third annual brief, which will be ready in the fall. We have looked at preliminary data and it's really exciting. We are seeing some really exciting positive trends with the data. I wanted to share this. This is our San Diego countywide chicks data from last school year. And it is representative of districts across our county. Over half are COPES districts. And the work we do with COPES, with trainings and all of the professional development, we offer it countywide. So we really, and of course, our role is to support all of our districts. So we do much of this data to the work we're doing. And what I want to point out is that we are seeing a trend of suicide ideation with our 7th, 9th, and 11th graders going down from 2% to 3%. This is lower than pre-pandemic data, pre-pandemic trends and pandemic trends. So we, if we look at the past 4 years, we have made significant progress. Similarly with chronic sadness and hopelessness, we are also seeing decreases from 2% all the way to 6%. For example, chronic sadness and hopelessness in 11th grade in academic year was wait, I brought it because I was like, wow, it was 40%, and now it's at 31%. So preliminary data, excited to see what comes when we get our COPES data. And so here, as I was talking about, the 2 years of work that we did was really about getting all 31 of our LEAs, and remember, we're talking 430 schools, to adopt an evidence-based suicide risk screening tool, to get trained on how to use the tool, and then to collect the data of the suicide risk screenings and the demographic data and report it to our evaluators. A lot of work, a lot of red tape, a lot of bureaucracy to get through to really get to this point. And so now we are starting to learn and look at this high level data. For example, last year, year to date, we have over 6,000 screenings that were done in 430 schools. 868 were high severity. Just last year, we started to ask more of our LEAs to tell us, give us the outcome of that screening and what happened. And so we're just starting to look at this data. We're looking at, what are some things that we're missing? What does this data really mean? And it takes time. We don't have any kind of standardized metrics to compare this to. I know there's some other counties tracking suicide risk screening data, but not quite sure how it compares to the work we're doing. So for example, we know that this past year, 5th through 8th grade were our highest numbers of screenings done, where last year it was 6th through 9th grade. So, okay, we have some comparison, but we don't have really any other way to compare this. So the need for metrics and standards really are there. And so laying this foundation is really creating systems change, and it takes time, and being able to look at this data in a way where we can accurately capture what are those trends and how can we ensure we're supporting schools to keep students safe and supported. Okay. So the need for ongoing funding is always looming with grants. And so we have 2 more years of this grant, but we are just starting to get this right. We have, for example, schools that have community-based partners that are doing suicide risk screenings in the schools. And some of them are just now getting the partners to share the data so that we have that data. So as you can see, this is an ongoing process, really building the leadership teams of each of the COPES LEAs to be able to continue this work beyond the grant years. continuing to track outcomes. We have over 130 schools that you'll hear about doing suicide prevention and mental health peer programming. And we have data that will be coming. We have data to look at where are we seeing those changes happening within the school. The peer programming, it takes 3 years to create sustainability. And so we intentionally have 3 years of peer programming, but we have to wait to look at those data and outcomes. Funding provides incentives for LEAs to collect the data. And so with this grant, we're able to work with our LEAs, the partnership to be able to collect the data and work with them to report the data. So without the funding, and we have, we need time to think through when the grant ends, how do we continue to collect this data and how do we create a platform to do that? So there's a lot of unanswered questions we still need to explore. And then systems change is a developmental process. And so being able to, the resource mapping project, how will that be sustained? How will the screening data be sustained and so forth? We've done some presentations at conferences where we share our COPS model and we provide all the resources that we have. And here, take it and you can replicate it on a smaller scale, but being able to take this further and have a replicable model we can scale up with the resources would be a long-term goal. And the need for statewide support. There's really no one state organization that's dedicated to student mental health. And because of that, there's a lot of just organic peer sharing and learning that we do. Our COEs across the state, our LEAs, our office leads a couple of statewide groups around suicide prevention and mental health and wellness. Just before I walked over here, a COE emailed me and said, hey, can you give me information on this legislation and how our districts are asking what is the best way to implement that. So we're working with each other, but we don't really have a go-to for student mental health expertise. And then CDE is great, but they lack the expertise and capacity in student school mental health. And there's legislation that requires them to develop specific resources for our LEAs. And for example, to support them, we worked with youth across the state to create the mental health posters that need to be in schools last year. So these are examples of how, again, we come together to do what's best and what we know is best practice, but don't have one office that has expertise on that. And then lastly, there are multiple state agencies and initiatives that lead this work across our state, but often it's misaligned because they're focused on specific initiatives. And we have so many different statewide initiatives that there's really no real great alignment of it all. So those are kind of the takeaways. And then lastly, just where are we going in San Diego this year? We're going to launch our referral pathways for cohorts with our LEAs to really continue this work. Meeting with one of our pilot LEAs and hearing kind of how do the referral pathways work for them. One COPS liaison shared the story that she met with a student with an eating disorder, and normally I wouldn't know where to refer the student. And because I had my comprehensive referral pathway, I was able to connect that student to services and support, and they got medication and therapy all within a week or two. And that's just, I want that for every school. And so knowing we piloted this and we have the tools to be able to replicate this in other schools, we're really excited about. We have a partnership with the American Academy of Pediatrics. And one thing we heard from our COPS districts is we don't have a communication system between the medical sector and the education sector. So too often we see our students with suicide ideation, with mental health crises, who get crisis support or get hospitalized and re-enter the school community and nobody knows what happened. So the medical community, education community came together. We've done focus groups. We brought a constitutional legal expert to talk about HIPAA, FERPA, and we're looking at piloting a re-entry with a school district and a group of medical providers and of course, our hospitals. So that in our policy to practice suicide intervention toolkit, we have taken it and enhanced it. So we have a whole reentry tool to be able to have both sectors use. So we can share information, communicate to ensure students reenter the school community with a web of support and make sure they're safe and supported. So excited about that pilot this year. And then we are excited because we were awarded the latest MHSSA funding to create a roadmap for mental health universal screening in schools at the county level and the state level.
Thanks, Heather. Thank you for sharing like the statistics that you did. I just want to say it's really nice to see like the work connecting down and resulting in improved trends for their kids. So I really appreciate that, sharing that. So I'm just going to give a quick MHSSA update. The commission recently held a competitive bid process to award 25 million in funding. The scoring process is complete, and so today we are going to formally announce the awardees for that. So just as a reminder, the RFA proposed 25 million. This was the proposal that you guys heard in February. You approved 5 million for marginalized and vulnerable student populations. That included groups that like peer support models, foster youth, juvenile justice involved programs. There's a universal screening cohort that Heather mentioned, where we're going to have partners come together to develop a roadmap to implementation for equitable universal screening. There was 9 million allotted for sustainability to develop programs for quality improvement sustainability coordinators so that these programs can find ways to sustain them themselves. And then we had another quick category where we got some really interesting proposals from counties to improve nuanced populations, geographical issues, and help solve those issues that they're seeing in their student population. So category 1 was marginalized and vulnerable youth and focused on programs in those populations. We awarded a total of 5.5 million. So the reason that there's a little difference between the 5 million that was approved and the 5.5 million that was awarded was we only had 9 applicants in our sustainability or universal screening cohort category. So we had 800,000 left over. And so what we did, we were able to award in another awardee here and then one in category 3 to make up that 800,000. So we awarded Trinity County for a coordinator, a mentor for At Promise Youth, Mariposa for a peer-to-peer support program, Orange County for a youth empowerment and ambassador program, and that is ran by current and former foster youth. Tehama for peer mentors for foster and justice involved youth. Riverside was also a peer mentor program. Alameda, an advisory council for foster youth that includes a job shadowing component. Amador for social emotional learning counselor, specifically for at-risk students. Sonoma County, a youth transforming justice peer solutions program. So it's a restorative justice program.
Could we just go ahead and go through the slides and not necessarily get them all named, but I'd really like to get to our guest of honor.
So these are the counties for universal screening. And then sustainability. I think this information is in your packet, but not the specific programs they were awarded for. There's 20 of them, so sorry about that. Category 4, the other programs here. And then the update on our technical assistance strategy is that we had a meeting with the technical assistance TCT providers, which are Imperial, Placer, and Tehama, and they are developing curriculum for the Learning Collaborative on September 4th. The RFA for the statewide coordinator is going to go out in September of 2024. Scoring announcements will take place in October, with the announcement in November, and then contract execution hopefully by December. And then We have Rachel Wagner here. She's the Student Wellness and School Culture Project Specialist for the San Diego County Office of Education. And she's going to share information on one of the MHSSA programs used in San Diego County, Hope Squad.
Thank you. And we'll go back to discussion. I just want to ensure that our guest of honor get to present to us. So if we could, thank you, Ryan.
Yeah. If you want to stay next slide, I can forward it for you.
Okay, perfect. Good morning. Do I need this? Yes?
Yes,
Okay,
because
yes, I need it. I'm gonna start, well, Ryan introduced me. I'm Rachel Wagner. I'm the project specialist for student wellness and school culture here at the county office. I work with Heather Namore and I co-lead the COPES grant. As a part of our COPES grant, we have spent a portion of our funding on peer programming, which Heather mentioned. We have a very special group of people here today to tell you very explicitly what that peer programming is and how it's impacted themselves and their school communities. To preface that briefly, I'd like to pass around just this one pager, highlights the programming that we have brought to the county. We do have 134 schools participating in peer programming. That represents 24 districts and charters. And that will be growing this year. There are schools who are trained and ready to go and were not able to launch last year that will be launching this year. We brought in 4 evidence-based programs to the county. We offered all 4 programs to the LEAs, to the applicable LEAs. We provided them with the research and the assistance to help them make the decisions about what would fit their model best and what met their needs. So we have Hope Squad is our largest program in the county. There are currently almost 80 schools participating in Hope Squad. Sources of Strength has about 50 schools. Bring Change to Mind and NAMI on Campus. Bring Change to Mind has about 30 schools. NAMI on Campus has a handful, maybe 5 or 6. I hope those numbers add up for you. Hope Squad and Sources of Strength are very unique in that they are elementary programming in addition to middle and high school. So Hope Squad starts in 4th grade and goes up through 12th grade. And there is a co-teaching model where the older elementary school students can go into younger classrooms and share some of the lessons that they're learning. Sources of Strength is a K-12 program. And so these programs were unique and really filled that need for elementary peer suicide prevention programs. Well, while we're waiting, I can tell you, Bring Change to Mind is so Hope Squad and Sources of Strength are specifically suicide prevention programs. Bring Change to Mind is a high school mental health club, and as is NAMI on Campus. They're similar models. Bring Change to Mind is unique in that with our contract with them, they hired a San Diego regional advisor to grow and expand their San Diego County presence. And so our schools have an advisor on site locally. Next slide, please. So just some quick context about Hope Squad and what you're about to hear. Hope Squad is an evidence-based suicide prevention program. It is included in the Suicide Prevention Resource Center's Registry of Best Practices. They are in thousands of schools across the United States and Canada. However, in California, there are only 2 counties that are offering Hope Squad, Irvine and San Diego. The program runs primarily through peer nominations. So students nominate peers who are kind, who are good listeners, who are reliable and responsible friends. And then the teaching staff, the school staff sort through those nominations. They lift up the nominations that are recurring. The school staff decides who to invite into that squad. The Hope Squads have regular meetings. They plan school-wide events and activities. They also do a lot of lessons together as a Hope Squad that the advisors teach. So in elementary school, they focus on some of the topics that are on your slides. In elementary school is more focused on SEL content and mental health. And the secondary levels, they really get into more of the suicide prevention. So I am, without further ado, thrilled to introduce a Hope Squad from Descanso Elementary School. They've driven about an hour to see you today, and they are here to share a little bit about their experience. Yeah. Are they able to control the clicker?
Yeah, so they have it right here. It's working now. I just got it to
Why did we join Hope Squad? I joined Hope Squad because I like to help others. Also because I'm kind and I care. Another reason is because people trust me to keep their information private. For example, they come up to us and talk about their feelings. I joined Hope Squad because I want to help others. I joined Hope Squad also because I want to make a change in the world. Also, I want to show people I care about them. What impact has Hope Squad made? The impact Hope Squad has made is more people are more comfortable to talk to us. Also, my family is more open to talk about situations, and I think they think I'm more mature to listen. The impact Hope Squad has made also, students make better decisions in life. For example, like what to do and what not to do. The Hope Jar. The purpose of this activity is to share thoughts, reflections, or messages of hope with each other. Now, please take a few moments to reflect on your own experiences with mental health and hope. It also doesn't have to be about mental health. It can be about hope in your community or hope for yourself. Now please write down a short message related to hope, resilience, or support on the piece of paper. They have pieces of paper for you guys. It's awesome.
Does spelling count?
Yes, it does.
We're in school.
In school. Wait a minute.
Sorry.
Now we will walk around again, and please take one piece of paper out of the jar. It will most likely not be the paper you wrote.
The three wrote our books, we're gonna join on this part.
I got my own.
You got your own. Okay, put it back in.
Oh, no, we switched. We
Okay,
switched.
good,
We're good.
good. Okay, there you go.
You got mine.
I don't know. We'll swap. I don't know which one I have, but.
Now you can choose if you want to read it out loud or keep it to yourself. Let's hear your start. I got, you are you, don't ever change that.
Aw. Pass the mic.
There's always someone there for you, keep going and know you're valued and loved. Never get up when it gets hard. Love yourself. You are valued and loved. There is always an open ear to listen.
You are cared for.
Tomorrow is a new day and a new opportunity to do better, learn, and get it right.
I have a future. My parents will be happy to hear that.
There's hope in the future and we can do better.
Please keep yourself safe. Never harm yourself. Always talk to someone to help you with your problems.
Mental health can be improved by practicing good wellness skills to train your brain.
I have such great hope and I'm filled with so much inspiration witnessing you young people share your messages and brilliance with us.
I hope for our students to feel loved and that their school cares for them and is there for them at all times.
I hope that all of your dreams come true. Thanks for what you're doing to make the world a better place.
Hope, wonderful to see young people sharing their thoughts on mental health. That gives me hope.
We are connected. When you do well, I do well.
I have the strength to overcome any challenge in life. Believe in yourself and you're halfway done. I hope that students feel supported in both their personal and their academic life.
Thank you for participating in the Hope Jar.
Innovation.
Thank you so much, first of all,
That was awesome.
for coming all the way to us. We're so happy that you're here. And we have some items for you, right?
We do.
We do, all right.
Do you want to take questions or do the first and then question?
Yes, commissioners, questions for our students. I don't think we got names.
Oh.
So, do you have your names?
I'm Santia.
I'm sorry, I didn't.
I'm Santia.
Santia?
I'm Sterling. I'm Noel. I'm Aubrey. And I'm Mackenzie.
Perfect, thank you so much. I want to ask if our fellow commissioners have any questions or comments.
How has been the response from your peers, your friends in your classroom? What do you hear from your friends?
Well, I've been hearing, like, there's more people that are willing to speak to me, that are willing to speak to us, and, about, like, issues with them. So, like, people are more like, how do I put this? People think we're more trustworthy.
So I have a question. So you guys go to work, right? When you wear your red t-shirts, right? That means you got a job. So you wear them to work that day when you're on duty. So does that let everybody know that's when they can come and talk to you when you wear your red t-shirt? Do other kids come up to you and say, hey, how can I get involved? Do they do that? Because your red t-shirt is so cool. Thank you.
I have one question. Are there certain students that come to you more often? Tall versus short, boys versus girls? Are there certain students that come to you?
Mostly sixth graders.
Mostly sixth graders. Wow, that's interesting.
Talk about the buddy bench. Lana, ask them about the buddy bench.
Buddy bench?
Yeah.
Buddy bench.
Yeah.
We get to like, so it was like this old bench that we used to have by the fourth grade class. And we kind of made it the buddy bench, and we moved it to the, like, right by the fence, and nobody was using it because it was all crowded. So last year, some sixth graders told Miss Ippolito and Miss Dunn that we needed to move it so people can use it more. And since we moved it, people have been using it.
So you moved it away from the fourth
More,
grade?
a little bit more private. Too many people were around it, just eating their snacks and talking and it wasn't confidential.
So we were unaware, we thought, this is a
Yes.
great spot, this is
Yes.
as adults, and then they came to us, like,
Yeah.
it's so great, let's help you
Yeah.
out, yeah.
Yes.
And so now more people use it.
What is the buddy bench for?
The buddy bench is like where if they're like feeling sad or they don't have anyone to talk to, and they will go sit on the buddy bench, and if we see them, then we go over there and talk to them and ask if they want to hang out with us or what's wrong.
Wow, so it's like a safe space, so somebody knows to go sit at the buddy. I bet we could all use a buddy bench. Yeah, I think we need a buddy bench.
Yeah, I'm thinking about that.
That's beautiful, and you know what I really appreciate? I appreciate that you were able to tell your teachers, we need to move it, and they said, that's right, let's do it, so, thank you, teachers.
So what, I know you guys help other students, but what do you guys do when you're having a no good, very bad day?
Yeah, we go to each other.
Oh, peers do.
That's right, here.
Right.
Two questions. What do you like most about being on the Hope Squad, and what was a surprise once you joined on? What's something that you learned, like, oh, I wasn't expecting this?
One thing that I like about Hope Squad is that a lot of people come to us, and it feels like good that they trust us to keep their secrets or something.
What others, like, what do you like the most?
I like the most that we get to just like help each other in general. I just love making people smile every day.
That's awesome. Any surprises that you learned since you've been on the Hope Squad? Okay, if you don't have any surprises.
Yeah. Actually, last year when I was in it in 5th grade, I was surprised that 6th graders would come up to me, like because I was a grade lower than them. I wouldn't think that they would come up to me.
That's great.
Yeah, I think that's it.
I just wanna say I'm excited about your future and I'm a peer too, and there's lots of careers in mental health and I look forward to working with you all. You guys get bigger.
Started now. So that's
Right now.
That's right. You're a model to us all.
Yep.
I want to thank you all for being our superstars today. I want to thank your advisors and your counselors because we can't do this alone, right? We have to do it together. So another round of applause for.
I'm the principal of the school, so I do want to point out that our 6th graders from last year, they have moved on to middle school and they're seniors were with the folks in the junior high and also ages going in. So hopefully it's creating more awareness and knowledge. Thank you for that.
We're gonna get a picture of with the kids, maybe we can have all the commissioners and staff down in the back.
Sure.
Sure.
Yes, please. Would that be okay if we take a picture of them?
Commissioners in the back. Stand in the front here. You stand in the front of the table. Maybe we'll have all the commissioners in the back.
I think that's fine.
However you want to do it. Yeah, just 4.
Yep. I'm kind of short. Congratulations.
I can be in the back.
Okay, I mean, I know I haven't grown that much since I was your age. I gotta stop.
So tall. Well, look. I look tall.
I know, I mean, I kind of do look tall, I feel taller.
All right.
There we go, right here. Look at me. 1, 2, and 3. Perfect. Thank you, everybody.
All right. We have some gifts for you. So. What do we have?
Thank you so much. I think I got it.
Did you get the video?
I got a few.
I told you. I believe it.
Strong work.
Yeah, that was very encouraging.
That's medicine.
It was very encouraging.
And then to be like,
Okay, in that case. In that case, I saw nothing. In that case, it's not L.
But she was able to make it.
Well, 45 it says.
Thank you.
Hello to you.
How you doing today?
Good, good.
Elijah didn't
We will make sure.
She just cares about the goodie bags.
Okay, we'll get. We'll grab it.
Appreciate it.
We'll make sure that you.
No, I have it.
You have it. All right. I just need to sign it, right? I signed it.
Yo-yo in years.
I know, I love it. Yeah, I love it.
All right.
All right. Right. All right, ready?
Thank you. I'm ready.
All right. What are we?
Thank you guys so much for your time. I want to thank everybody on Zoom for your patience. We're very excited to have our guest here presenting with us. At this time, were there any questions or comments regarding the presentations that we saw? Commissioner Carnevale.
Thank you, Madam Chair. A lot of great stuff there. Most of you know, I'm passionate about the screen part of this, but the one thing that jumped out at me is that my 15 years of experience in education, having started the UCSF Dyslexia Center, has taught me two things. One is that we aren't going to really solve our literacy issues until we solve our mental health issues, which is why they need to be coordinated. And that's my second point, which is I just want to double down on the fact that the two systems are really separated from each other more than they're together. And so therefore, I guess what I'm wondering and thinking is I love this idea, of an office, but, if we set up another office that's floating out in its own silo, it's just going to add to the problem. And to me, it only makes sense if it is a joint office that's embraced by HHS and CD, or it sits in the governor's office or something like that. So that's what I would suggest we think about, perhaps building our recommendations.
Thank you. Yes, Commissioner Carnevale, I agree with your statements. I also see Commissioner Gordon. Please, Commissioner Gordon.
Yeah, thank you. I couldn't agree more with Commissioner Carnevale. I think an office is way too little because we have two huge systems, some of which are good at some things. The others are good at other things. And I think we need to have a very high level come together with health. And we're going through something right now where that didn't happen. So now we're struggling to deal with this fee schedule issue. But the point is we have 9,800 plus schools in California. That's a huge asset. We have access in places the health systems don't have access. And there are so many other opportunities to use schools for things that they're good at in both delivering and screening for health issues. So I won't go on with this. I'd be happy to share some thoughts with the staff about the report. But again, I think in the interest of pushing prevention rather than treatment, there are many things we can do to push this down much earlier in our systems. Now we're having young people start school at 4 years old, and we have entree into the 0 to 5 space. So I think we really need to take advantage of that and do what we're good at. And build a culture of prevention and early intervention throughout our whole system. So we're not just needing to do treatment. But I will work more, Chair, with the staff if that's helpful.
Yes, absolutely, Commissioner Gordon. I think that's something that staff have asked both of us to really work closely with them and, you know, considering also what Mr. Carnevale is saying, an office is too small and floating by itself is not right. And assuming that it should just sit with either one, CD does well for the academic side of the house, but they're not a mental health expert. And this is too important to make an assumption to just open it.
They don't even want to be at it. It's part of the problem, I think.
And then, thank you. And so, taking that all into consideration, yes, thank you. And I think we can all agree that we absolutely need, along with that, the metrics and how we do measure what we treasure. And I'd also like to lift up the importance of measuring wellness. We don't do that. It's, you know, at best, the California Healthy Kids Survey. And why aren't we looking at wellness? Why is it just, we look at the questions that we have on California Healthy Kids Survey and talk about innovation. There's conversations happening, the work of Dr. Jeff Andrade, and amazing work happening there. And I think we need to lift up those types of things where the focus is on student wellness and really looking into that. And it goes along with prevention and setting up our school systems where kids feel safe and respected. And, you know, if you look at the report, there's comments of what students said around mental health, and what students focus on aren't necessarily give me more school counselors or give me more mental health professionals. They want safe environments. They want passionate teachers who understand. So the 4 comments that are in this report, one of them was bring me more mental health professionals. They want relationships and caring environments. And so I think to honor student voice is critically important and stop making these assumptions that adults continue as we build out the systems. Any other questions, comments?
Just one, wonderful $280 million investment, but what's next? What is the sustainability of some of these great efforts?
I think that's the question, the big question that all of us have. And so we're hoping that this most recent round of grants for the RFAs, paying for employees, like a personnel grant for folks to specifically, that is their job and their scope of responsibilities to find sustainability options. It's going to give us a lot of information to answer that question.
I also just wonder, I also want to acknowledge this idea of safe spaces, welcoming environments, and like the larger narrative that's happening in California and across this country, right? From book bans to anti-trans efforts, like that trickles down to young people. They're showing up on the campus that is expected to support their educational development, but also who they are. It's shaping who they are 8 hours a day. And I really want to commend this commission and its commitment to school mental health for years to really lay the groundwork for California to hopefully lead the way in creating these types of environments. And it's a continued fight, right? In the legislature, these issues have repeatedly come up. And I expect that it will continue to come up and figuring out how do we support schools and being these incredible community hubs that they are. So just really want to applaud the efforts of this team.
Just briefly, I want to comment following on Commissioner Bontrager, because the issue of sustainability is often an issue because the place where you spend the money is not where you capture the value. And this is a classic question. I'm mentioning this because I think it's an argument for a multidisciplinary office or entity, because this while you may see literacy rates impacted, the cost that gets served with kids that have mental health issues isn't generally seen in the education system. It's seen in the community, in the healthcare system, and in the policing system, and in all the other systems, which is why you've got to have something that's larger than just education or even HHS to deal with school-based mental health, I think. And that's how you begin to get to sustainability, by recognizing and connecting the dots.
Any other questions or comments regarding this? Okay, so at this time, I am going to ask for public comments. We're going to open the queue for any public comments regarding this agenda item. Daniel, are there any public comments? Please raise your hand now as the queue will be closing.
We do not have any in-room comments. And it does not look like we have any virtual comments either.
Right, then we are going to, this was an informational item only, so there is no vote. So we are going to move on then. We are going to pause for a lunch break. At this time, we will return at 1:30. So we're going to break, return at 1:30. At that time, we will proceed. All right, thank you, everyone. All right, welcome back, everyone. For agenda item 9, we will discuss the implementation strategy and future planning for Proposition 1. At our July commission meeting, we began to discuss some of the changes to the commission under Proposition 1, including the composition of the commission. At our July meeting, several of our commissioners agreed to work with staff to plan for our priorities, goals, and vision for changes associated with the size and composition of the commission, the role of committees, branding of the commission, and onboarding of new commissioners. I'd like to invite Zendra Zoller, Deputy Kendra Zoller. And too many carbs at lunch. I apologize. I would like to invite Kendra Zoller, Deputy Director of Legislation at the Commission, and Jigna Shah, Chief of Innovation and Program Operations, to provide us with an update on the progress of these areas. Ladies, please go ahead.
Okay, good afternoon. I'm Kendra Zoller, Deputy Director of Legislation, and I'll be guiding the commission through the implementation of Proposition 1. At our July meeting, I provided an overview of the upcoming changes, particularly focusing on the January 1, 2025 expansion to 27 commissioners. Over the next 4 months, we'll be concentrating on 4 key areas to ensure a smooth transition: meetings, committees and subcommittees, onboarding, and our name change. Our staff has been collaborating with commissioners to develop proposals for these areas. Today, we'll update you on our progress. First up, Jigna Shah, Chief of Innovation and Program Operations, will discuss our plans for meetings, committees, and subcommittees.
Thank you, Kendra. As discussed at the July meeting, beginning January 1st, the commission will grow to 27 appointees. Since July, staff reached out to multiple state-level boards and commissions with a list of questions regarding the operations of their boards in order to get a better understanding of how our structure may need to change in order to continue the work of the commission while also supporting the mandates of the BHSA. The boards that we reached out to are the California Workforce Development Board, the California Coalition on Aging, and the Behavioral Health Planning Council. We met with them to discuss board size, meeting structure, and the role that their committees and subcommittees play. We learned that the frequency of board meetings varied from 4 times a year to as frequently as 10 times per year. And several of the boards had multiple functioning subcommittees whose role it was to bring recommendations to their full boards on a variety of topics. We also heard an interesting idea around the potential to have multiple satellite locations across the state to host commission meetings. And we are working with our chief counsel to discuss our ability to do that within the requirements of Bagley Keene and within our staffing capacity. As part of our research, we also looked at the content of our commission meetings from August of 2021 to July of 2024. And we identified how much of our time is spent on action items versus informational items. We did an analysis of the data to help us understand the ideal number of commission meetings and the ideal format and role of subcommittees for the commission to operate effectively. So some of our key findings include that 52% of the commission's time was spent on action items, including voting on legislation, innovation, and approval of grants and of policy reports. The remaining 48% of the commission's time was spent on informational items, including announcements, public comments, and updates on projects and policy projects. So in 2023, the commission spent approximately 30 hours on action items. Breaking that down, that means that approximately 6 meetings, a minimum of 6 meetings, would need to occur each year just to accommodate the action items and general public comment. So we will continue to break down this data and we will work with Chair to bring forward recommendations on this. We also met with the CLCC this week and got their feedback on the commission and committee structure. Some of the feedback that we got from the CLCC included ideas for specific committees, including an Innovation Partnership Fund Committee and an idea for having a legislative committee. The CLCC also highlighted the importance of having the committee and subcommittee include representatives of underserved communities, including BIPOC populations and the LGBTQ community. We plan to meet with the CFLC at their next meeting and gather feedback from them as well. So today, what we'd like to do is hear from our commissioners about your experiences around large boards and to hear your thoughts on how we can ensure that our meetings are effective and efficient. So we'd love to hear from you all on that.
Pause here if you want to have comments, and then I can do mine after that. If there are none, I'll just keep going.
I'll just say that I like the ideas. I look forward to you all. I was kind of jealous, like what you guys hadn't came talk to us yet, but you guys will be to come talk to our committee. So I'm excited. I like the idea of a lot of business being done in committees so that there's time and analyzation of some of the stuff. I just don't think there's enough time like in the meeting. So I think that it would give the other commissioners more autonomy to take on more tasks and in these committees, if that's what I'm hearing, potential idea, right?
That is one of the ideas, yes.
Yeah.
I want to just point out that committees by law they can be only recommending bodies. So the only entity that can actually approve and get actions done is the full commission meeting. So you can advance, you can, move the ball forward in committee, but the committee would still need to come and make the presentation to the full commission to act on anything.
I appreciate that. I think that the work, so doing the work in the committees and the analyzing it and then being able to advise the full commission, I believe would be like ideal, because coming here to these meetings, if you don't read the stuff or then you're just voting on stuff or not really understanding. So I think that that's a good way to get the ball rolling on the business end. There's more of a watchful eye, and then the public can weigh in, and potentially it sounds like maybe in these committees, which would be good too, so they could probably weigh in multiple times on funding opportunity or legislation. Yeah, I really like that and embrace that and excited wherever we go, but I endorse that.
I also wonder, I don't have any preference at this point, but did you find any of the organizations would have a longer board meeting, but fewer of them, like where they do it over 2 days or something like that?
Yes, so there were some boards that had meetings over 2 or 3 days.
Yeah.
Where they often would go to an offsite location.
Yeah.
And have their meetings for 2 or 3 days and have less frequent meetings.
To me, 3 days would be a lot, maybe too much, but 2 days, we're already sort of taking 2 days by the time you travel and you get there, so that doesn't seem like a crazy thought. And then if you separated the site visits and they were their own thing, then, maybe that could have fewer meetings that are longer.
My experience with the board of regenerative medicine board, that board was comprised of all of the UC schools and their appointees, and then other legislative appointees. So I'm sharing that because the composition of the board was about 30 individuals. So it's comparable in size. Two things, and it was governed by the Bagley Keene Act of Proposition 70, I believe it was, is the funding mechanism for the regenerative medicine board. So there is, in terms of overall size, some similarity, maybe a place where you could talk to someone about just their structure. And in particular, they have a very robust funding sort of structure for grants. They give a lot of money in grants, and all of their committee meetings and their board meetings are governed by Bagley Keene. And as council said, the committee work comes back to the board, and the board adopts the final decision, but the structure works for a large group. So that's why I raise it as an example. Vice chair, I had the privilege of watching her manage a committee meeting. And I do think that there's an opportunity for us to utilize committees in a more robust way, provided all of us as board members understand the commitment that we be making to those committees. Vice chair's commitment is stellar, because not only does she have to prep, but to also be prepared for the nuances associated with public comment at that meeting. And then that's the last point. What I love about the commission and what I hear about the commission is our public comment and our commitment to transparency in the public comment. And you said in the data that X amount of time is dedicated to public comment. That is important. And whatever structure that we come up with, as long as it, from my perspective, reflects that we were mindful of our commitments for transparency in the public. The Regenerative Medicine Board does not experience the kind of public comment period that this board does. And so it is a unique, in my opinion, very positive feature that we would not want to reduce by virtue of reducing the number of meetings. And so I'm so glad that you use data to analyze it and make the initial assertion that it looks like a minimum of 6 meetings would be necessary in order to accommodate public comment. I hope people who are listening heard that is important in my opinion.
Can we reach out to you to get a contact at the Regenerative Medicine?
Oh, sure.
Thank you.
Absolutely.
Okay, I have a couple more comments about meetings. Our meeting planning for the coming year will align with opportunities outlined in Prop 1 that was mentioned earlier. We are coordinating with the administration to schedule presentations on key areas such as population-based prevention, substance use disorder, housing, workforce accountability, and transparency.
These discussions will help us explore how the commission can best support these initiatives, and we'll kick off with a panel discussion on early intervention next month. Also related to meetings, we need to address how the commission delegates authority to the chair and executive director. This will require a formal commission resolution, as the last one was in 2011. Once passed, this resolution will be integrated into the rules of procedure, which will also need formal adoption by the commission. We recommend making these decisions after the expansion to 27 commissioners, as their input would be crucial on that. So expect that. Okay. Moving on, we'll revisit our discussion from last month about adopting an informal abbreviated name for the Behavioral Health Services Oversight and Accountability Commission. We're working with Commissioner Carnevale to enhance our messaging, elevate our mission, and develop a cohesive brand guide to ensure consistency, clarity, and strong brand identity. We believe the California Behavioral Health Commission is a fitting nickname, and we are consulting with other commissions like First Five to learn from their experiences with using a nickname. And we also plan to gather feedback from the community about that. We also explored ways to improve the onboarding process for new commissioners. Our goal is to align priorities, focus efforts, and ensure a thorough understanding of the commission's functions and objectives. Staff, in collaboration with Commissioner Robinson, are developing an onboarding outline that includes team building activities and exploration of individual motivations and approaches, and comprehensive training on our programs, external partnerships, performance expectations based on our strategic plan, and budget and finance training that will cover budgetary processes, funding sources, and financial oversight responsibilities. This is so the commissioners can understand the commission's various funding categories, like the Mental Health Student Services Act, Mental Health Wellness Act, Advocacy, ALCOVE, Early Psychosis Intervention, Full Service Partnerships, Innovation, Research, Communication. We brought these two items before the CLCC committee, and we plan to do the same with the CLFC, as Jigna mentioned. So that concludes my update, and I welcome any thoughts or suggestions from commissioners regarding branding and onboarding. Your feedback will be valuable as we finalize our proposals over the next couple of months.
Commissioner Gordon? Did you have a comment?
Yes, thank you. Well, first I had a question. Is there a rationale that was given, or what was expected to happen as a result of adding the 11 new commissioners? What was the gestalt around doing that in the first place? Were there statements made? In other words, so that the new members will come on board, and we can share with them the way the commission operates. But what will they come on board with? What expectations will they come on with in terms of their idea of what the commission might do differently?
Thank you, Commissioner Gordon.
Well, I mean, I think if we're gonna do onboarding, that should be a back and forth process, I think. So that we're learning about, we're getting a better understanding of what they're expecting in terms of what the commission will do, not just what we've cooked up to do before they got here.
So in conversations with the administration regarding the additional seats, I think there were a couple of drivers behind that decision. One is to strengthen the representation on the commission with the various seats, particularly around the integration of traditional mental health with the SUD space, which is, and so, two new commissioners representing people with lived experience with substance use disorders, two new commissioners representing family members of people with substance use disorders, representatives of people with expertise in housing, right? And so reflective of the priorities of Prop 1, that was one, aspect of this. The other really was, growing interest in serving on the commission and creating opportunity for that. The onboarding conversation it's a, I think, really unique opportunity. Over the last 10 years or so since I've been here, new commissioners would come on, one, maybe two every year, every other year. And so onboarding was done one-on-one, and usually staff would spend some time meeting with commissioners, and certainly trying to make ourselves very available. Some commissioners really taking advantage of that, others not, having the time or didn't want to prioritize that. And it was I will learn by showing up, recognizing that it was one new commissioner who would often be partnered with someone on the commission to help kind of get acclimated. And so some of the commissioners are relatively new. And what we wanted to do in this conversation was to ask you, what would have been helpful that we did, what was helpful that we did, or what would have been helpful that we didn't do? So we can really benefit from your personal experiences. I remember driving out to meet with Mr. Bontrager and sitting down with him for a couple of hours, and, it's an overwhelming, amount of information. And it is, and it's more of a, gonna take a year or so to get my commission legs and be comfortable and figure this out. And at the same time, it was relatively easy for a single individual to join the commission with a new perspective and to slowly sort of shift some of the agenda to reflect that new perspective within the patterns of work that the commission was pursuing, just recognizing capacity, right? So that's going to be very different with adding 11 new members all at once. And also want to recognize that, many of this, the seats, even for the seats that are filled today, there may be some turnover, right? We recognize that the governor can make appointments for those seats that have, their terms have expired. And so it actually may be more than 11. We don't know, right? The appointments unit, they engage us all the time on questions around interest or the process or time commitment and those kinds of questions. But the appointments process is their decision and theirs alone. And so sometimes we get a heads up the day of an appointment, but oftentimes, it's unusual to have more advanced notice than that. So we don't know actually what will happen. So Commissioner Gordon, I think, we want to be responsive and learn from sort of what we've done right and what we haven't done right in the onboarding for those of you who have been with this commission for some time, or who are relatively new and maybe still remember what it was like to be, first day of school, right? And how can we ease that transition? And at the same time, create opportunities, particularly in this January meeting, or as you point out, Commissioner Gordon, a chance to hear from new members of, why they applied for and what they would like to accomplish. I want to recognize that we have a strategic plan. We worked very hard on that strategic plan, and, and we're dedicated to, it's by design a multi-year strategic plan. It's broad enough. The commission certainly has the discretion to go in a different direction, but it's broad enough that we fully anticipate that it will be more about the nuances of how we do the work rather than a complete rethink of what the opportunity is. So, what the staff really wanted to do is use this time to hear from you and get guidance so that we could, do our work over the next 5 months to get ready for January and make sure that we can hit the ground running in ways that are supportive of the decisions that you're making, including working with the chair around what happens in January when we anticipate we will have new members. We don't know if the appointments will be made in advance of January. Like they could be made in November, but not take effect until January. That would give us some time to do some one-on-one with individuals before they're actually on the commission, or appointments could be made January 1st. And we would have 22 days or so for the first meeting. that would be a challenge.
Yeah, well, just as a couple of suggestions, having helped on board a lot as a school superintendent, a lot of new board members. I might suggest that we at least pair them up, each of them with a commissioner to be their helper or their buddy or whatever. Because I think the risk is that you'll have two groups, the old commissioners and the 11 new, and you don't want that. You want them to really integrate and become a part of the overall group. So.
Commissioner Chambers is questioning whether a peer strategy is the right strategy.
He said it, I thought that. I mean, I had someone to help me, just to your point. Thank you, Commissioner Gordon. But I think this commission is so welcoming. So I think that just goes well. I think everyone would step up to that. My only also thing of improvement as well is like, for the TAY and for individuals, I don't know how people's financial situation is gonna be. I know the team works really hard to, book our flights and stuff, but the reimbursement process potentially could cause challenges for individuals. I mean, even myself, I don't got it like that, but to wait for that. So just thinking, I don't know what the state procedures are relative to reimbursement, but I know for a fact that will be a challenge. So with costs and stuff like that.
I would just make one other comment. Toby, I came on board when it was during COVID, so I was thinking, well, that's not really relevant, but actually it is, because when I came on board during COVID, you would just meet on Zoom, and I didn't get much of a sense of anything, in the course of the first year. So it was a reminder that, like anything else, you get out of it what you put into it, and the ability to meet in person is important, and attending committee meetings, going to site visits, all that, and it's less clear, I think, outside why it's important. This isn't you show up and you just give your opinion about an issue. You're learning so much from such a diverse group that you end up making decisions as a group, and so you got to be part of that group to get in the flow of it. And I think that's what should be communicated to the people who are picking and choosing. This isn't, a casual thing. This is a big commitment if they're going to be effective. So I don't know if that's helpful, but.
Yeah.
I also think, there's almost as if is there a job description for a commissioner? Because I think there are different opportunities for a commissioner's role on this commission and what that actually looks like. What are the activities commissioners can do? You can show up at meetings and vote, and that's it. You also have the opportunity to weigh in on these special projects within these buckets. You also have the opportunity to lead specific initiatives that come up, right? Robin's reading one, Commissioner Carnevale is reading another. I think outlining those opportunities for new commissioners helps people better understand what the level of engagement can look like for them. I think that would have been really helpful. I've been very impressed by some of our newest commissioners that are just jumping in and doing all that, because it took me a couple years, right? It was more like sitting back and observing. And I don't know what the promise is for the new commissioners, but there's some great ones that are bringing new perspectives to our work that could strengthen, our implementation of certificate. I think that would be really helpful. And then the other one is, you've done tremendous work. And so outlining those projects, right? Like the progress that's been made with school mental health, the progress that's been made with work-life mental health, the progress that's been made, walking people through that, and the fact that it didn't happen overnight, I think is our helpful reflections to know how we as commissioners can contribute to future opportunities. So I do over again.
And I think at one time, myself and Vice Chair Alvarez, but when we were still talking binders, 2,000 years ago, but we had asked for kind of the division of put it all together where we have the projects and where we have the reports. And because it is important for them to know everything that's been done. And whatever role they have on the commission, it's, you get people with where their interest lies. And so if they know where, you know, okay, the school mental health report, the workplace mental health standards, you know, that's where we tie in, you know, where we have the interest. And so I think that's important to know that there are no limitations. So if they are interested in, you know, bringing SUD conversations into the workplace, what does that look like? And having that bridge with the mental health standards, for example. I think sometimes we can sit here, especially when you're new, and you don't know something's going on until it's mentioned in a conversation. It's like, how did I not know anything about that? And yet they could have really contributed and want to. So I don't know if it's a clearinghouse, I don't know, you know, because I'm going back to the binders, but if there could be a place to really walk up there, it's really dovetailing from what you said, Vice Chair. I think that would be really helpful. And I could not agree more with the strategy that Commissioner Gordon said and Chambers. The peer, you know, adopted commissioner is, I think is just really important. And I know when I reached out to some of our commissioners coming on, it's going to be so important that you talk to this person and that person, and they'll be able to walk you through certain pieces. But that was in a conversation. There should be like a checklist, like this is what they need to hit. And so it's, you know, whatever that might look like. Please. You all decide.
I'm question for Commissioner Carvalho, since he represents business. Do you view your business perspective now with a mental health view? Do you tie those two together? Like, how does mental health impact the business environment? Prior to coming here, did you think like that?
Did it change my thinking?
Yeah,
Sure,
okay.
but I didn't come here trying to serve the business community, really. I really felt my first priority is to serve the citizens of California around this issue, and then use my background as expertise where I can lend more assistance than others. Inevitably, I do think about some of the workplace mental health, though it would be one of my areas of interest and expertise, I suppose.
And see, I think that's real important because we all come from different places. Because everywhere I go, whether it's in my work, whether it's, you know, speaking at something, I make it clear that I'm gonna always come from the parent, the consumer place, because I'm a client. And so I think it's important for, my ear is still plugged up in my flight, so I just probably got ready. But I think it's real clear, I mean, it's real important for us to help make new commissioners understand how mental health ties into everything. So if you're appointed by, you know, the governor of the assembly, the senate, whatever that appointment is, it's for the mental health of that particular industry. So I think that is just so important, because that's what we are, that we're now the new Behavioral Health Commission. But I'm very clear on that I'm gonna always speak for families. You know, because families, again, typically don't have a voice in these circles. So I think that's super, super, super important for them to get that type of orientation, that you're representing the mental health for that industry, for that place. And my conversations with Commissioner Carnevale are always beautiful, because he shows that there's an integration of that workforce, healthy mental health in the business world. So as far as my orientation, I think I was newly retired. So I had time. I was very pleased to be in this, among these people, this group. But of course, now I'm working retired, so you have to really do make time for this. It's not an easy feat. It really is not, if you're committed.
Sometimes there are things that are obvious are overlooked, and so I want to really emphasize what Commissioner Gordon said about the question to ask the administration, what their expectations are. I don't know what type of answer you will get, but I certainly think that it is a great question, Commissioner Gordon. The thing that I would say this morning that I experienced, Toby, was you provided a very succinct description of AB 34, AB 2034, Prop 63, and then we moved into Prop 1 as it pertained to FSP. And that very succinct history, I was sitting next to Vice Chair. She said, that's helpful. Well, it is helpful. It is helpful to get a history of the role the commission has had as it pertains to Prop 63 and Prop 1 as a part of that orientation. And so I appreciated the history orally because our former CEO was a commissioner. And I got to hear what the work of the commission was early on. That helped me be more effective here. For new commissioners, I think that they need something a bit more tangible and deliberate. These are the key points in the history of the commission that we want you to pay attention to.
Commissioner Robinson.
Yep, I agree with everything that's been said, and I think it's important when in bringing on new people that are new to the process and maybe new to appointment process to share snippets of the wins that the commission has had. I think that's something, I'm still kind of learning it, but I think it would be very helpful, would expedite understanding of the work if you share, like, we did this, we did that, we accomplished this. And I think that's important because it would help make things make sense as we go through our deliberations. The other thing that I think would be helpful is if there's a way for current commissioners to share the why of the commission personally. So, maybe a video or something, a very small snippet sharing, I do this because, and hearing that helps people find their own why, connect the dots for them, and it can be really, really powerful. So I just think that'd be very valuable that we do something like that when we onboard our employees, and I think it would be helpful for new people too. Great idea.
So you're saying take us Hollywood.
Go Hollywood. We're in California.
LA.
There you go.
Come to LA.
Instagram.
Thank you, Commissioner Robinson. Other thoughts, comments?
So there's a real controversial thing here, the name. So I know MHSOAC is not real, never has, but are we committed to the Behavioral Health Commission? Where does that come from and where are we at with that?
Well, I think that, and we're still subject to debate, but I think part of it was we're trying to streamline the process, so we didn't open up, we don't have that much money to do that much branding. So the question is there is an easy place to land? And our kind of subjective view is when we talk to different people, that today it's kind of referred to as a mental health. That's what I think most people know us as. So just calling us a behavioral health commission seemed like an easy land. We also talked about creating a tagline, which gives you an opportunity to create additional positioning. And that's where we were thinking of embedding more of the creative thinking around that. So that's how we got this far. But if there's an alternative point of view, then certainly we'd love to hear it.
We haven't heard any other suggestions from the community yet, but we're still welcoming
I mean,
it.
you don't want to name that you have to make up the people after them. Like I said, I still can't remember MHS OAC after that, which is embarrassing, right? When you're on it. So it should be something we can easily all remember without remembering it. We named it Gazappy weed or something. So, it's, anyway, that's where we got.
Are there any thoughts about anything else?
Just the commission.
The commission. Oh, it's real Hollywood.
All caps, all
Yeah,
caps.
that's.
Well, and in our community, we do that, in fact, right? I don't even talk about it as a mental, I just say the commission,
Yeah.
and people know it's shorthand in the mental health.
Well, I think when a commissioner is talking about it and we say the
Yeah.
commission, it's implied that it's, yeah.
There you
I
go.
agree.
Yeah.
But I wonder if other commissions would be a little.
I know, but in behavioral health, a lot of people know the commission, just like that.
In behavioral health.
In California, the commission. And I'm not talking about the boards, though. I'm just talking about
Right.
people in our field know this commission, as the commission.
But if it was any other discipline, he also has commissions, then what do we do? So, say.
No, I don't I'm not saying do that.
Yeah.
We're going back.
Okay.
On record.
We need more coffee.
Yeah.
Right. Other thoughts?
Yeah, this is Dave Gordon again. I just think if it's at all possible at the earliest date to bring all of the new commissioners or as many as are appointed at one time together in person with all of us, the existing commissioners, and make it a day-long event with briefings and all of that, but just something where everyone can interact and have a meal or two would be very, very welcoming to the group.
Thank you, Commissioner
That's
Gordon.
a common way to onboard boards is to have a retreat of sorts, like a day or two. You pick a nice location, you do bonding, team building, and then you do like an hour of Ledge, an hour of Bagley Keene, an hour, But I mean, again, that's the fun stuff, like the contracts. I can talk about.
But that still has to be
Yeah, conflicts of interest. I can do an hour on conflicts of interest.
that still has to be a public meeting,
Of
right?
course.
Yeah.
We have
Sure.
That makes it a little different, but yeah.
But breaking bread is always a
Mhm.
really good way to. Thank you, Commissioner Gordon. Yes, we are taking note of that. So, yeah. Thank you, ladies, for bringing these items up. We're gonna go ahead and take note of all that.
Yes.
All right. And thank you all for your contributions to the conversation. We are going to move on to public comment now. And Amariani, I'm going to ask you to open the line. And do we have, please raise your hand or press *9 so that we can open lines. Amariani, do we have public comment on this item? If so, could we go ahead and get started?
Yes, so we do not have any public comments in the room. We have 2 virtual comments. Our first comment is from Stacy. Your line is open.
Hello, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I think it's a good idea that you are discussing these things. In my experience, and of course this could be very different, but I find it really optimistic that you believe you will have all the appointments made by, or that the governor will have all the appointments made by January 2025. In my experience with this commission, there have been times when it was almost impossible to get a quorum because the governor's office had not appointed vacant positions. And to think that, and again, I'm sure maybe Toby has a lot of grease and he can get it going, but I mean, 11 new positions before January, I mean, or like, that's why I'm encouraging you to go ahead and form your committees and start working on Prop 1 and onboard people as they come, because if you wait, I mean, I just can't imagine that all 11 are going to be on by January 2025. And if it is, that's fabulous. But that is why I keep harping on the Innovation Partnership Fund, because if that begins in July 2026, then working backwards, if there are to be any RFPs, they must go out at least 6 months in advance of when you want to begin services. So even if you had a committee on this begin in January 2025, that's only 1 year to develop an entirely new RFP for an entirely new responsibility or program of your commission. And selfishly, for BIPOC and some LGBTQ communities, this Innovation Partnership Fund is one of the most important and sought after aspects of the commission. So that is why I keep harping on it. I think it's great that you're, again, considering how you're going to move forward with the commission being changed in such a dramatic way. But like I said, I think my teeth would fall out if all 11 new members were going to be appointed by January 2025. Thank you.
Thank you, Stacy.
Our next public comment is from Jay. Your line is open.
Can everyone hear me?
We can, Jay, go ahead.
Great. Hi, you may have seen me before. My name is Jay Calcaño. I am with the California Council of Community Behavioral Health Agencies. First, just wanted to echo Commissioner Rowlett's comments on uplifting the role of the commission subcommittees, as well as the role of public comment to bolster the work of the commission, especially as you add on new commissioners in the upcoming months. And just wanted to say that there's a lot of uncertainty amongst providers, including the ones that are represented by CBHA, on exactly how Proposition 1 is going to impact their ability and capacity to provide services, especially for programs that are overseen by the Oversight Commission. CBHA, of course, we are willing and very committed to working with the Commission on the implementation of Prop 1, especially as it concerns the changes that are going to impact the Commission itself. And we share the Commission's goal of ensuring that California's most vulnerable communities continue to have equitable, comprehensive access to the services that they need in the communities where they live. And we just wanted to uplift that provider perspective to the Commission as it considers these changes. Thank you for your time and consideration, and I will pass it back to you all.
Thank you, Jay.
And then we got one last public comment from Steve. Your line is open.
Yes, can you hear me now?
We can, Steve.
Thank you. I have a couple comments. One is going back, with all due respect to all the effort and work that's been going into the studies on how much time you spent on informational items versus action items, I'd like to point out that everything is changing. And if you look back over that time, you had a lot of time spent on action items around innovation, and innovation as we know it has changed. And you also have a new situation with lots of new people. You'll need a lot of informational stuff. So except as a baseline and as a part to move forward from, I'm not sure that studying the last year or so or whatever of these meetings will give you any real insight what the ideal number of division of topics are and times to meet per year. So everything's changing. And you might find ways to use that data, but it's not necessarily important. And I would like also to make the point that I share with Commissioner Gordon the fear that you could have a group of the new people and a group of the old people. Not only are we talking about different people, we're talking about different subjects. I mean, there's an overlap, but technically, what you're moving into now is not just dual diagnosis, which has been by default in the mental health court for a long time. You're moving towards pure substance use. And that's a whole new ballgame. And you're gonna need to be up to speed as much as they are. You know, and so that's a whole new set of issues there. And finally, last but not least, something that I shared, an opinion that I share with former Commissioner Katara Tompin, and that is that in the consumer communities, recovery as it's used in the mental health community by mental health consumers, even with the overlap in substance use as opposed to mental health, that word recovery actually internally means something a bit different. So it's like, oh, we all can agree on recovery. That's what we're doing. But it's not quite so simple, and you're going to have to deal with that too. So I'm just putting up some caution lights about moving forward. And I also agree with the point that a lot of these decisions are going to have to be made after they're there. I'll tell you, nothing would be worse than if I came onto a commission in a new thing and they said, well, we've already decided what you're going to do. So there I am, and there's my ideas. Thank you so much.
Thank you, Steve.
That was our last public comment.
Thank you, Mahani. I want to thank you, Kendra and Dignan, for sharing your knowledge. We look forward to having you share more on the implementation efforts around BHSA and the next steps. And you know, we gave you a lot to consider, and we're all in this together, so we will keep moving forward with that. So at this time, so it has come to our attention that it will be posted, or it has been posted, regarding the appointment opportunities. So that will be on our website. I'm getting this message wrong. I'm going to ask Toby to clarify.
Yesterday, the governor's office issued a press release announcing new appointment opportunities for the Boating and Waterways Commission, the Board of State Community Corrections, the Department of Toxic Substance Controls, and a few others, including this commission. And so they have asked us to share widely that they're encouraging people who are interested and who meet the eligibility criteria to submit an application. And so we're sending out that press release to our through our listservs and our social media marketing. And it lists contact information for the governor's appointments unit. Basically, the application is on the governor's website at gov.ca.gov under the appointments link. And so we'd be happy to share with any of you and anybody else who's interested information on the process and what it means to serve on the commission. But to be clear, we're not involved in the decision in the appointments process. So they did ask us to share very widely that they're actively seeking appointments for the new seats. So I wanted to make that part of the public record.
You're very welcome. Okay, thank you. I want to thank everyone for being here virtually and in person. This concludes today's meeting. Thank you all for your participation and engagement, and we look forward to seeing you all in September. The meeting will be held in Los Angeles, so we will see you there. Take care, safe travels back home, and the meeting is adjourned.